أهلا وسهلا فيك دكتور أحمد. You can.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
السلام ورحمة الله وبركاته.
دكتور ميرزا صباح الفل.
حياك الله بروف، كيف حالك؟ طيب؟
أخبار سعادتك إيه؟ الله يبارك فيك.
يا هلا بك، الله يخليك.
دكتور بطاية.
أهلا وسهلا، حياك الله دكتور أحمد.
عام وأنتم بخير. أنا معاكم إن شاء الله وفاتح أهوت، بس هنزل بس زي ما اتفقت مع الدكتور ميرزا. عندي بس مريض في الان بيشنت، هطمن عليه بس كده واجي تاني، يعني مسافة مثلا نص ساعة ساعة
دكتور
بالكتير.
أحمد، أنت فاتح الرابط حق اليوتيوب؟
لا،
في عندك إيكو يا دكتور أحمد.
عندي ايكو.
أيوه.
طيب استنى لحظة واحدة.
أنا سامع كويس.
طيب استنى، سهلة.
كيف صوتي يا أبو خالد؟ مضبوط؟
ممتاز، تمام.
ممتاز.
بس سوي رن للتست مرة ثانية.
كده كويس. انا حطيت
ممتاز.
سماعات اهوت. كده
تمام،
كويس.
ممتاز. اكسلنت.
راح الصوت. طيب
أيوه تمام.
طيب تمام. احنا كده I will share my screen في الباوربوينت برزنتيشن، مش كده؟
أيوه نعم.
تمام.
شغل الباوربوينت، شغل الباوربوينت أول وبعدين تسوي الشير. أي بالضبط. وتختار نفس الباوربوينت اللي فكيته.
تمام ممتاز. اوكي حاضر ماشي. طيب انا هستأذن، بس هنزل اشوف المريض، وعلى 10 ونص كده ان شاء الله اكون عندكم باذن الله.
طيب حياك الله، الله يسهل لك.
ربنا يخليك. اتفضل يا بيه، اتفضل.
الحين البرزنتيشن أول واحد اللي هو المفروض يبدأ مين؟
أنا.
طيب. واللكشرة الأولى؟
أيوه. لا، أول شيء انترودكشن.
تمام.
ممكن تبدأ أنت، وبعدين نبدأ الانيشال اسسمنت ونمشي على نفس ايش يسموها المحاضرات.
تمام. لأنه اوريدي احنا الساعة 9:05 we should start.
الحضور إلى الآن 66 بدون أن احنا معناته 63. نبدأ أحسن مو؟
أفضل لي.
طيب تفضل. تحب تسوي انترودكشن سريع؟
طيب. بسم الله الرحمن الرحيم. بسم الله والحمد لله والصلاة والسلام على رسول الله. Dear doctors, we welcome you by the International Medical Surgical Aid. This is the first webinar that we are going to introduce for you, the Trauma Assessment and Management Review course. Our goal is training of medical personnel in their remote area to increase the level of health in this area and to promote the autonomy. We will teach you and guide you through this webinar to organize yourself in trauma management. We will start we will start now and we will end inshallah by 1 p.m. So far we have around 250 participants from 21 different countries and who cannot able to attend through the Zoom and the link and the registration by Zoom. There will be a link through the YouTube. So feel free to share it, and you can attend also via the YouTube channel live transmission, and you can interact and start chatting. First of all, I would like to welcome our host also and my colleague, Dr. Mohammed Mirza.
Okay, thank you very much. Can you allow me to share my screen? Bismillah ar-Rahman ar-Rahim. My name is Muhammad Amin Mirza. I am Assistant Professor of Surgery, Consultant General Surgeon and Emergency from Al Qura University, Al Noor Specialist Hospital, Mecca, Saudi Arabia. So our talk will be about trauma. This is first webinar we are giving through international surgical and medical aid. تفتح لي الشير please.
حاضر.
The idea came behind this idea was just to share knowledge and to try to deliver what we have to everybody, especially to the doctors who are in a remote area. Okay. Okay, so the trauma assessment and management will start by what called initial assessment. We are trying to simplify the information and to make it as easy as possible, and we'll address various aspects of trauma management, especially when you deal with these trauma in the hospital. So first of all, we need to prepare ourselves. Preparation starts by triage. Triage is a it is a sorting of patients. When you get a multiple casualty, you will find that you need to minimize them just to get a good opportunity to deal with all these cases. First, you need to categorize them to the most critical and to mild critical and minimally critical patients. The most critical will take the first priority for management and according to the resources you have. This topic is very huge topic and needs another course just to address and how to make a triage. So triaging is very important initial step for preparation. Then you need to also prepare your equipments, your all resources you have in your area. And of course, we'll talk in the next slide, you need to wear standard precautions to deal with these patients. So once you receive the patient, you need to start primary survey and do resuscitation according to the protocols you are following. And always you have to think, if you don't have the management or the definitive management in your area, you need to think of transferring the patient to another place. So standard precautions, gloves, goggles, gowns, shoe covers, face mask, everything should be well. All members of trauma management should be well equipped and well protected, because this victim could be a victim of chemical weapon, it could be a victim of industrial problems. So we don't want to make our personnel and ourselves exposed to these hazards. So what we do first, we start with primary survey. In primary, these are the phases of trauma management. First is the primary survey, containing resuscitation and re-evaluation of patients. And we have a secondary survey where we go and do detailed examination of patients. And at the end, we have to think of transfer to definitive care and re-evaluation. In trauma management, we have a little bit different way of management than in regular patients. In regular patients, what we do is just to go and talk with the patient, say, hello, how are you? I am this, and so you are chatting with them. Here you have a critical patient who is maybe not talking to you, or he is in severe pain because of his wounds and he have no time to talk to you. He is just crying or he is unconscious. So here first you need to find out whether there is life-saving problems in this case or not. So in primary survey, you have to look for life-saving problems, life-threatening problems, discover it, manage it, do the resuscitation. Once your life-threatening problems are addressed and everything is fine, and you have re-evaluated everything, then you go and do, so you will have a time to do secondary survey, take a detailed history, do a detailed examination to your patient. So what is primary survey? Everybody knows it is A, B, C, D, E's. So the knowledge is there. Everybody knows what is A, B, C, D's. But here we are trying to bring everything together and make it a type of a protocol so everyone can go through the management smoothly without having a trouble, especially when you get many patients and you get a very critical case. So you have to go by this protocol, A, B, C, D's. A means airway management, protection, and C, spine protection. Airway and C, spine protection. B is breathing with adequate oxygenation and ventilation. C is control of circulation with control of hemorrhage. D is disability. E is exposure and environmental control. So always in initial assessment, the primary and second primary survey and resuscitation of vital functions are done simultaneously in a team approach. Always you have to have a team. Every member of your team should go and do one of the one part of your ABCDs. One will do the airway management, the other B management, the third C management, and the other is documenting. Fourth is going to bring things which is not available. And someone can make communications with others, and so everything is done in the same time without delaying your patients. So how do we quickly assess our patients' airway and ABCDs? Talk to the patient. Ask him what is his name, what happened to him. If he answers you, means his airway is patent, and he is realizing that he is in the hospital, for example, so he has a good breathing reserve and good perfusion to his brain. So it is very quick way to assess. Hello, how are you? I am Dr. Muhammad. What happened to you? He's answering to you, this happened, this is my name. So it means he is fine. You will have, I'm going just through a main important things of ABCDs, and in next lectures we'll talk about many about every priority separately, and we'll give you more details how to manage airway, breathing, and circulation. So in A, always don't forget to protect the C-spine. We don't need to examine how is the C-spine, but we need to apply something, or if we don't have, we have to establish a good control by our hands just to give an inline immobilization. So the neck movement can expose this patient to a problem, especially if he has some just subluxation, which will become a complete injury and transection of the C-spine. You will have sometimes some problems during airway management, like equipment failure. So as we said, preparation is very important. You have to check all your equipments, intubation kits, medications, everything are ready and functioning well. Sometimes there will be a difficulty in intubating patients, so you have to give a chance to someone else. Always keep in your mind to try to call for someone else to help you, especially anesthesia people, ICU people who are more expert in intubating patients. Always you have to keep in your mind that airway management could be difficult and sometimes could be occult and hidden, like in inhalational injury. They come with a clear voice and clear airway, but the edema is slowly growing. So at some time, this airway will become blocked. So always when you have a patient with signs of inhalational injury, you have to keep in mind that this patient might need intubation as soon as possible. Trauma to the neck and expanding hematoma can obstruct the airway progressively and expose the patient to a progressive loss of airway. In B is breathing, is to assess and ensure oxygenation and ventilation. Check your patient, see the respiratory rate, chest movement, air entry, percussion, and his oxygen saturation. And always try to maintain a good and adequate oxygenation and ventilation to your patient. Patient can have many life-threatening problems. Examples for that: airway obstruction, tension pneumothorax, open pneumothorax, flail chest, massive hemothorax, and cardiac tamponade. So when you assess the breathing, you have to look for these problems and look for its signs. We will talk about it in coming lectures. And you have to find it out. If it is there, you have to manage it immediately without any delay before you go to the next step. Always in trauma patients, you have to provide a supplemental oxygen. Every patient should start with high flow oxygen until you finish your ABCDs and you be sure that he has no problem, and then later on you can take away the oxygen later on. But don't delay any supplemental oxygen to this patient. If he has a B problem and you didn't give an oxygen, he will suffer from hypoxia and he will get troubles later on. C, circulation. You need to assess patient for organ perfusion. You have to look for signs of inadequate tissue perfusion. Inadequate tissue perfusion is a definition of shock. So when I have a decreased level of consciousness, skin color, temperature are changed, cool skin, cold temperature of the skin, pale skin means he is having a hypoperfusion. The pulse rate tachycardic and very thready low volume pulse means also inadequate tissue perfusion. We don't look for hypotension because hypotension is a late sign of shock. If you see your patient hypotensive, your trauma patient, means you are in a late stage and you have to move faster, resuscitate very fast, and decide very fast. Always you have to keep in mind that you have to control the hemorrhage. So if you don't control the hemorrhage, just giving fluids and fluids and fluids will not be beneficial. It is like a big tank and having a large hole there, and you are trying to fill it while it is escaping out. So you have to cover that area, so prevent escape of that water, and then you can fill it with whatever you want. So just to summarize, we need to establish a good IV access. So you should have a peripheral line to this patient. You have to take blood for cross-matching, blood grouping, cross-matching, and basic investigations. You have to start with fluid resuscitation, and then you have to look for hemorrhage and to examine the patient to look for the hemorrhage to control that one. So control hemorrhage, restore the volume, and always reassess your parameters. Elderly, children's, athletes, patients on some medications will have a different way of response to your to the trauma. So elderly who are on beta blockers and some medications will not show an increase in heart rate. So you will not find tachycardia. Athletes are not having that much tachycardia because they are used to be under stress always. So you have to be careful in these age groups. So how to stop bleeding? You need to stop bleeding by many things, either by direct control, by direct pressure, or you can have a tourniquet, especially if you see that this patient is profusely bleeding and you cannot control it just by direct pressure or by dressing. You have to apply a tourniquet. Reducing the pelvic volume by making a pelvic binder. If you don't have a pelvic binder, you can use just a long sheet and wrap the pelvis. Also, splinting the fractures will minimize the bleeding. If you have a facility, you can use angioembolization. And of course, operation is one of the types of bleeding control. What other problems? You need to have a good urine output. How do I know that this patient is improving and getting good resuscitation? By having a good urine output. And these are the numbers of normal urine output, up to 2 ml per kg for neonates, for small children's up to 1 ml per kg, for adults and children, school children's 0.5 to 1 ml per kg per hour. You have also in pediatric, you have a Breslow pediatric emergency tape. This tape is very nice tape. You can use it for pediatric age group. And once you see the, just you measure it, you see, until you see, you reach to this area. Here, if you read, you will find every medications and fluids and his weight, all information you are in need for resuscitation. Aggressive and continued volume resuscitation is not a substitute for manual or operative control of hemorrhage. Sometimes some doctors are just giving fluids and fluids and fluids. That one is not enough, and it is not management. We have to think always of operative control of the hemorrhage. If we found out that there is intraperitoneal hemorrhage, you have to take him immediately to OR and to control that hemorrhage. So C management is not just giving fluids and blood products. We will talk in shock, we will talk about damage control, resuscitation, how to give fluids, how much to give fluids, when to give blood. And nowadays we are minimizing fluid management and going more towards blood and blood products, and always stressing on operative control. Disability is just a documentation of a baseline neurological evaluation. You need to have a Glasgow Coma Scale scoring and pupil response and signs of lateralization. If he is moving his limbs or not, moving upper, not moving lower, not moving all quadrants or all limbs, so quadriplegic, for example. So you need to write that in your documentation, and always observe for neurological deterioration. In exposure, you need to remove all his clothes. It is full of dirt, and if he is a victim of industrial problems, so it will be full of any objects or any things. So you have to remove everything, undress him, and then cover him to control him from, to prevent hypothermia. So, and then log roll the patient, see his back, see if he is having any injuries. And always you have to keep in mind that he is warm. Hypothermia is an enemy of your patient. Always you have to keep him normothermic. You have to prevent patient from hypothermia. So always we are resuscitating at the same time. Once I discover the problem in A, I have to resuscitate. I have to establish and protect and secure the airway. I have to ventilate and oxygenate if I have a problem in B. Always we have to stop bleeding and restore the volume in C. So as you see, in every step, I am finding a problem and treating it at the same time, and then moving to the next step. I have many adjuncts to primary survey. I need to use many tools to help me in diagnosis and management of patients. Check vital signs, check ABG if you have a problem in B. Pulse oximeter and CO2 detector is very important. Urinary and gastric catheter is important, and you have to insert it in all patients. You have to insert NG tube and Foley's catheter. Of course, you have to think first whether it is contraindicated or no. For example, a bleeding from nose and sign of base of skull injury. You have to be careful when you, and you should not insert it nasally, you insert it orally. And always check your patient's urinary output and do ECG for all your patients. Also, we have what called FAST, Focused Assessment Sonography for Trauma. Just we need to check for quadrants and look for intraperitoneal bleeding. If it is positive and your patient is hypotensive and not responding to your initial fluid and blood management, you have to think of surgery. And always these patients who are not responding to your adequate resuscitation and volume restoration will need a surgery. So you have to always think of surgery once you have a positive FAST, while he is your patient getting a good resuscitation with blood and blood products. And also you have to think of transfer. Don't delay your transfer for diagnostic test. Don't do X-ray of his foot and lower limbs, upper limbs, and delay him for transfer. If you don't have the facility, sometimes you are in a rural area where you don't have a surgeon, and you are resuscitating, and he is he is critical and not responding well, and he needs a surgical intervention, and you don't have that one in your hospital. You have to keep in mind that this man needs a transfer, and you have to arrange that transfer as soon as possible while you are doing your ABCDs without any delay. You can use the time before transfer for resuscitation. So resuscitating continuously and arranging the transfer and transferring him as soon as possible without any delay. As you see, we have done ABCDs without any delay, and we don't need sophisticated things to do the ABCDs. It is very simple things to do. Once we finished ABCDs, we need to move to secondary survey. Before we do secondary survey, we have to recheck all our ABCDs and adjuncts. Have I done fast or no? Was there a chest X-ray for this patient or no? Follis catheter, NG tube. So everything is done and he is fine. And now I move to secondary survey. I do full history, physical examination, complete neurological examination. Now I can use some special tests and evaluate our patients. I'll go a little bit faster now because it is very detailed, just to address the most important points. So starting from the history, we have a mnemonic called ample history, asking for allergies, medications, past medical history, the last meal, and if he is also pregnant or no, if she is pregnant or no, sorry, and ask for events and environment. What happened to this patient? What was the mechanism of injury? So I can guess or anticipate the problems from the mechanism of injury. So mechanism of injury could be blunt or penetrating. Blunt injury from direct impact to the patient. So if we have to ask whether he was rolled over, was he ejected from the car or no, means he will get spinal injury and multiple body injuries. Penetratings injuries will give you an anatomic factor, means the penetration to a specific area will give you an injury to that area. So you will not go away from that place. And injury, energy transfer factors, the velocity of the weapon, the caliber of the bullet, the trajectory, and the distance from the victim himself. So starting from the head and scalp, looking for any wounds, any depression over the bone. So examining entirely and looking by your eyes for any possible injuries and document that one. Raccoon eyes gives you an idea that it might be a base skull injury. You see the raccoon eyes. And you have to examine the eyes, looking for any hemorrhages, conjunctival hemorrhages, and so on. A back of the ear, this one called Battle's sign. It is also a sign of base of skull injury. You have to look to the ear for hemorrhage or for CSF otorrhea. The nose for any fracture signs, deformation, and for CSF rhinorrhea, bleeding from the nose. Maxillofacial examination. Maxillofacial examination is important. So you have to look for the zygomas, for the arches, just to find out whether there are fracture or no. If there is a complex fracture, that one could be a potential threat to the airway obstruction. So if you have a complex facial fracture, facial injury, you have to think of airway obstruction or possible airway loss. And as you see, this man, due to his fractures of the face, he got airway obstruction, swollen tongue, and they have done surgical airway management. C-spine should be well immobilized and to protect it. And now in secondary survey, you can slowly remove this one. Someone will help you to hold his spine, and you can examine his back, the whole back, just to look for C-spine deformities and injuries. In the neck also, you will look for any signs or any injuries, sign of injuries, hematomas, expanding hematomas, tracheal shifting. These signs, you can see it from the beginning, if at the time of admission, whether there are tracheal deviation, engorged neck veins, which is a sign of tension pneumothorax and presence of any life-threatening problems. In the chest, look for lung expansion, auscultate, percuss, and look for any signs of chest injuries, rib fractures, simple hemothorax, simple pneumothorax, signs of ruptured diaphragm, and so on, which can be evident in your chest X-ray. Also look for signs of seat belt or signs of any external injury, which can give you an idea that this patient could have chest injuries and also intraperitoneal problems. Perineum should be examined. Always we have to examine the perineum, look for any injuries and document that one, especially rectal injury and perineal organs injuries are important and need to be addressed as early as possible. Pelvic fracture, if you still did not examine, you need to examine the pelvis and see whether it is stable or not. If it was examined, you have to be careful because excessive examination and manipulation of the pelvis, which is fractured, will be hazardous to the patient. It may increase the bleeding and you may lose your patient. So once it was examined and you found that it is unstable, wrap it and just keep it like this until you transfer the patient to the needed specialty. Extremities are a potential area of blood loss. As you see, tourniquet were applied, and this one was run over by a car during Hajj period, and patient lost his both limbs, and it was very bad trauma. So you have to resuscitate the patient. We stopped bleeding, and then we took him to refashion this amputation area. And always you have to keep in mind that the limb is well perfused. If it is fractured, you need to make inline immobilization. You have to wash this wound with copious saline, and then cover it with clean dressing. And always these injuries are attracting you from management of the airway. So always you have to have a team someone will go and manage the main priority, A, B, C, Ds. This one is a C priority. So someone will stop this bleeding, and then you come and manage this wound after you have done your A, B, C, Ds very well. And of course, X-ray is not mandatory now, unless you have a time, then you can, and it can change your management plan. You may do X-rays, but don't do X-rays and delay your patient from a definitive care. Also keep in mind a compartment syndrome. We'll talk about it in musculoskeletal lectures. Secondary survey, also done, you need to do a full neurological examination, examine the brain, repeat your glaucoma, see if there is some deterioration or no, signs of lateralization, and always we stress on frequent re-evaluation. And you have to keep in mind a secondary brain injury. We need to prevent the brain from secondary injury, which is from hypotension. The brain have got its injury, don't expose it to a secondary injury, which is a iatrogenic because of hypotension and hypoperfusion because of under resuscitation. So we have to keep that your patient in a good volume control. Spinal assessment is very important. The whole spine, you need to log roll your patient if still you did not do, and examine the whole spine, palpate and see whether there is a step deformity, whether there is tenderness and swelling. Complete your motor and sensory examination, reflexes, and if needed, some imaging like CT scan and so on. Of course, CT scan can be done, but still it should not delay your patient transfer. Patients who are unconscious, you cannot examine the patient's back and the sensors and tenderness. So you need to write down in your notes that your patient was unconscious and you couldn't complete the spinal examination, and you need to give a note that the receiving doctor should complete this examination. You see how he is immobilized very well. During transfer, he will not move even a small movement. He is very well immobilized. Special diagnostic tests are important to find out many injuries, but still it is an area of patient deterioration. It may delay your transfer, and always we have a poor communication. We leave the patient inside and go out, and he is alone inside. So we have to keep the monitor. You have to check your patient before you transfer him to CT scan. Once you are going out, again, you check your patient. If he is fine, everything is well, do the CT scan and then move back. If you feel any deterioration from the beginning, don't go to CT scan. If you are in need for transfer as soon as possible, don't do a CT scan. Pain control is important. These patients need a good pain management. The best medication is fentanyl, which is not affecting that much the respiratory system and circulatory system. It is better than pethidine and morphine, which can affect the respiratory and circulatory system. And it should be given IV, not IM, because patient is hypoperfused. Now we need to transfer the patient to definitive care. You have to think which patient needs. All patients with multiple injuries, with comorbidities, whose need is exceeding your institutional capability, you need to transfer him to a definitive care. When I transfer them after all life-threatening problems are managed well, and disabling injuries are stabilized, and arrangements are made. So you have to do all these steps before you transfer. And also transfer your patient before performing unnecessary tests and procedures. Thank you very much. This is the end of my slides. If you have questions, I can answer questions.
Thank you, Dr. Mirza. And it is the opportunity now, if anyone would like to have any question directed to Dr. Mirza, please raise your hand so that I can allow you to talk. Or you can use the question, the Q&A panel, that you can type down your question and we will answer you. So please, who had a question, just to raise his hand, or just write on the question and answer panel and we will answer you. So the question from Dr. Verma, sir, what if we don't have team? What is the suggested method to tackle when you are alone?
Okay, if you are alone, you have to go. If you are alone, you have to go by the priorities. So you go to A and then B and then C and so on. But I don't know whether there is an environment when you are alone. But as I said, always we go by priorities, A, then B, then C.
Okay, Mr. Ubaid al-Sheikh will allow you to talk so that you can, Mr. Ubaid, you can unmute your mic and
yes.
you can.
It's an honor, Dr. Batai and Muhammad Amin Mirza, that myself, Dr. Ubaid Sheikh, I'm from India. I'm a Unani physician. Just want to know, in a present scenario, if a person, especially affected with COVID-19, how to perform a respiratory emergency? How could we tackle a severe respiratory emergency?
Okay.
Okay. Although it is not a goal of our webinar, but of course, in COVID-19, what we do is to use the special precautions. You know, COVID-19 is moving by aerosolization. So you need to wear N19 mask and cover yourself with a gown and then go for intubation. Try to let the most expert one in intubation to do that procedure. So he will not need to stay for longer time in contact with the COVID-19 patients. So special precautions according to the guidelines. In 95, eye protections and gowns, and then a most expert one will go for the intubation.
Okay, Dr. Mirza, we have one more question. What is the time limit required before we transfer a trauma patient?
There is no time limit for that. What is guiding you is your patient's stability and your way of arrangement. Let us say you are in a rural area and this patient or victim of road traffic accident or fall down from height, and they immediately rushed him to your primary health care. Now you need to, you don't have any resources here, so you have to let someone to make their calls and to bring ambulance or what is available for transfer while you are doing your resuscitation. So once you established ABCDs, the ABCDs can be done in 10 to 15 minutes, maximum 20 minutes, you are done with ABCDs. Once you have done and everything checked well, now you transfer him as soon as possible, because you don't have any resources, and the more the patient stays in your place, the more you harm your patient. So always you have to make the arrangements as soon as possible, and you have to do your ABCDs during this arrangements. Okay.
Okay,
So
thank you
now-
so much, Dr. Mirza. Now we
Okay.
can continue our webinar with our second
you.
presentation. Our second presentation by our colleague, Dr. Mohammed Al-Ataibi. Dr. Mohammed Al-Ataibi, you are ready? دكتور محمد الساوند عندك مو مظبوط. We cannot hear you clearly.
Can you hear me?
Yes. Now it's okay.
Can you hear me now? Okay. I'm
Can you
afraid,
make the
I don't
screen?
have,
Can you make the
Yeah.
screen full screen?
yeah, no, inshallah. It's clear
Yes.
now?
Yes, now clear and okay. Go.
Okay. So, Assalamu alaikum. I'm Dr. Mohammed Al-Ataibi from Mecca and Noor Hospital. I'm really glad to introduce this presentation today, which is about airway and ventilatory management, which is a crucial part of trauma management and assessment. As Dr. Mirza goes with the initial assessment, A is a stand for airway, and honestly, airway is easy to miss and easy to recognize. Why it's first priority? As you know, it's the quickest killer in a trauma setting, and it can lead to secondary insult of central nervous system. More than 34% of the pre-hospital death due to trauma, it's coming from an airway mismanagement or airway unrecognized problems. So, as we say, the death from airway problem, it's come from failure to recognize the need of airway intervention, alternative airway, incorrectly placed airway, and the need of ventilation. Also, inability to establish an airway, displacement of the tube, and also aspiration due to gastric dilatation. So, recognize an airway problem. It can become all of a sudden, or you can recognize and it would be a progressive and partial. So always think about reassessment. Always think about A, B, C, D, E, and always reassess. So there are a few signs and symptoms to recognize for an airway problem, like change voice quality, dyspnea, agitation, tachypnea, abnormal breathing pattern. Don't look for the autosat immediately. It would be an late sign. So for the objective signs for airway obstruction, can be you can face an agitated patient. If you face an agitated patient, think about hypoxia, or also you can face an obtunded patient. Think about hypercarbia. Cyanosis will be a late sign for a trauma, and at that time you will be in trouble. Also, another objective sign, which retraction and stridor, tracheal shift, and patient behavior. What's the quickest way to recognize airway? Simply just speak to the patient. Patient speaking, that's patent airway, intact ventilation, and adequate brain perfusion. If patients not speaking, or Glasgow Coma scale below 8, so there will be an alteration of the consciousness. So you will go directly for a definitive airway. What's definitive airway? By definition, definitive airway, it's any tube below the vocal cord, cuffed and secured, and supplying an oxygen. This is a simple way of definition. So advantage of definitive airway management, it will be protection of airway, support the ventilation, maintain oxygenation, and prevent hypercarbia and prevent aspiration. For the immediate airway recognition of failure of oxygenation will be an maxillofacial trauma. You might face an fracture, dislocation of the structural support of the airway, hemorrhage in the mouth, dislodge of the teeth. Also, you may face a neck trauma, either penetrating neck trauma or blunt neck trauma. Also, laryngeal injury. It might lead to incomplete obstruction or complete obstruction. And if you face a laryngeal injury, likely you're gonna attempt one ATT. If failed, you will go directly for surgical cricothyroidotomy. Also, you have to recognize a ventilatory problem, which should be a mechanical or CNS depression. Mechanicals like direct chest trauma or pre-existing pulmonary dysfunction. Also CNS depression, either intracranial or spinal cord, that cannot lead to the chest to move. For the objective signs of inadequate ventilation, you might see chest rising, labored breathing, decreased breath sound, rapid respiratory rate, and finally, pulse oximetry in tidal CO2. So, how we assess patient initially? Initially, we will go for airway maintenance. We will add the C-spine protection, remove any object you see, like helmet, monitor pulse oximeter, suction, supplement patient with oxygen, and predict difficulty of airway. To predict difficulty of airway, this is a nice mnemonic, which is lemon mnemonic for difficulty airway prediction. As you see, look externally, you have to look to the patient for any facial trauma, large incisor, beard, mustache, or large tongue. Then go to the E, evaluate with rule of 3-3-2, which is, as you see here, the distance between the upper and lower teeth has to be 3 fingers. And as you see here, the hyomental distance, you should have a 3-finger breadth, okay, for easy airway. Also, the thiomental here, okay, at least it should be 2-finger breadth to have an easy accessible airway. Also, we use a Malambati score, which have 4 grades from 1 to 4. Grade 1, all the organs are visible: soft palate, uvula, and fuses pillar. But for the grade 4, you only see the hard palate. To do an proper Malambati assessment, you have to keep the patient in a neutral position, and mouth fully opened and the tongue protruded maximally without phonation, while you look to the patient in the front and at the eye level, and you inspect the pharyngeal structure with pen torch without any patient phonation. So finally, we will go for the obstruction and neck mobility. Obstruction, you evaluate the patient for stridor, for embodies, and for the neck mobility, it's vital and it's required for successfully intubation. You will assess the patient for later on ATT insertion, okay, for the mobility of the neck. So you will go for airway decision. If the patient able to oxygenate directly, as we say, you will go for lemon. Assess. If easy, go directly for intubation. If failed, use any elastic bougie, LMA. If failed, you will go for surgical airway. But if he's not able to oxygenate from the beginning, you will go directly for definitive airway, either ETT or surgical airway, and always call for help. Always call for your help. Position is crucial and very important for an airway maintenance. To establish a good airway, start with the chin lift and jaw thrust positioning, and never hyperextend the neck in the setting of trauma. Always think about devices. Always think about adjunct. You have an oropharyngeal airway and nasopharyngeal airway. We are so familiar as a surgeon with oropharyngeal airway. If you attempt an oropharyngeal airway insertion and the patient cannot tolerate, likely you will think about ETT directly. Oropharyngeal airway, it has to be a proper size. If not, it might lead to airway obstruction or insufficient oxygen delivery. Also, we have an supraglottal and extraglottal devices like laryngeal mask airway, laryngeal tube airway, multi-lumen esophageal airway. For the laryngeal mask airway, it has to be in a proper size with 30 kg to small adult and 50 to 70, 30 ml to the 50 to 70 kg. And for the big adult, it would be 40 ml and above. Indication for definitive airway, as we said before, either we are thinking about protection or we are thinking about ventilation. For protection, as we said before, severe maxillofacial fracture, risk of obstruction, risk of aspiration, unconscious patient. For the need of ventilation, like patient patient in severe bleeding. He's tachypneic, hypoxic, hypercarbic, cyanotic, massive blood loss and need for volume resuscitation, severe closed head injury with need for brief hyperventilation. So for the endotracheal intubation, as we said before, just manual inline and remove the C-spine. Either you choose nasotracheal or orotracheal intubation. For the nasotracheal intubation, we have to make sure that there is no facial or basal skull fracture. Again, I will not go too much through the orotracheal intubation, but always have assistant and someone to do a pair for you, backward, upward, rightward pressure to the larynx. Use a direct laryngoscope and gum elastic bougie. For infant endotracheal intubation, we used either uncuffed tube or cuffed tube. Okay, the age divided by 4 plus 4. For the cuff tube, age divided to 4 plus 3. Above 12, typically most adults using 6.5 to 8 mm tube. So, is the tube in the place? Yeah, we have to make sure by listening, equal breath sound or no bowel sound, because you might intubate the esophagus. And always make sure with X-ray and CO2 detector. Rapid sequence intubation is a good option for intubation. It has 4 parts, which is anesthetic, sedation, and neuromuscular blocking. For that, be prepared for surgical airway. Keep suctioning. Pre-oxygenate the patient for at least 3 to 5 minutes. Use a cricoid pressure and administer etomidate 0.3 milligram per kg. Add succinylcholine as neuromuscular blocking, and confirm tube placement. Then release cricoid pressure and ventilate the patient. For another surgical airway, which is cricothyroidotomy, which is indicated if fail ETT or you have obstruction of the airway, phlebitic edema, laryngeal fracture, severe oropharyngeal hemorrhage. For that, I will give you this short video for the cricothyroidotomy, not for cricothyroidotomy, sorry, for needle cricothyroidotomy, which is a desperate solution, and it's used as a bridging for definitive airway. I will give you this short video.
Attach a 14-gauge IV catheter to a 10cc syringe half filled with saline. Identify the cricothyroid membrane. Sterilize the site with betadine. Immobilize the larynx with the thumb and middle fingers of the non-dominant hand while palpating the cricothyroid membrane with the dominant index finger. Insert the transtracheal needle into the cricothyroid membrane at about a 30-degree caudal angle while withdrawing the syringe to look for air bubbles. Air bubbles within the syringe upon aspiration denote passage into the trachea. Advance the needle and catheter a few more millimeters, and then gradually withdraw the needle while advancing the catheter until the hub reaches the skin. Connect a 7.5 endotracheal tube connector to a 3 cc syringe with the plunger removed. Connect the 3 cc syringe to the catheter hub. Alternatively, one may use a 3.0 endotracheal tube connector to the catheter hub. Connect the resuscitation bag and attempt ventilation. Note that there will be significant resistance with insufflation. Apply the lowest effective pressure to safely deliver tidal volume with an inspiratory to expiratory ratio of 1 to 3 or 1 to 4 seconds.
So, as you see in the video, needle cricothyroidotomy, it's a bridging method, can be used with disparate solution. So maximum time for it, it's 1 hour using large caliber plastic cannula, 12 to 14 for adults, 16 to 18 for children. You will go through the cricothyroid membrane into the trachea and connect patient on auto or oxygen 15 ml per liter. Complication for that, inadequate ventilation, blood aspiration, esophageal laceration and hematoma, thyroid perforation, pneumothorax. Surgical cricothyroidotomy, it's not recommended for children below 12-year-old. Skin incision extend obliquely from the cricothyroid membrane, and you will use a small ATT or tracheostomy tube, and it will be inserted through the cricothyroid membrane, and it will be as an alternative. Complication for that, blood aspiration, false tract, supraglottal stenosis and laryngeal stenosis, hematoma, laceration to the esophagus, laceration to the trachea, mediastinal emphysema, and vocal cord paralysis. And thank you. Any question? Hello?
Thank you, Dr. Muhammad. We will see now if there is any question. Please raise your hand for asking for any question to Dr. Muhammad. In the question and answer, there is some question by Sayan Kumar. What if I get patient who require anesthesia and I don't know if he or she is asthmatic? What should I do?
Patient need anesthesia and he's asthmatic?
Yes.
Actually, in the setting of trauma, we are not concerned about asthma or other chest problem. It's a life-saving situation at that time. So the asthmatic patient will be like other patients. You will not have any concern about if he is asthmatic or not, because you're gonna intubate the patient.
Totally agree.
Yes.
So it wouldn't be making a difference. The only thing will be with the setting of your ventilator setup. One more question regarding can the nitrous oxide be used as anesthesia?
In the setting of rapid sequence intubation, we are not using nitrous oxide.
Okay.
If you allow me,
تفضل دكتور مرزا.
nitric oxide is not, as Dr. Otaibi said, not used in trauma patients because we need a rapid action and rapid work. To use nitric oxide, you need a time first. The second thing, you need to have it purely so it will act faster. So here you will deplete the oxygen and you will make another problem. So it is not used. We use some different rapid acting medications like fentanyl, like succinylcholine and midazolam. Thank you.
Okay. So I think we can move to our next presentation.
I think there are a question here from Vijumbora. How help then as its contraindication in patient under 12 years, the cricothyroidotomy? If I understand the question correctly, she's asking about cricothyroidotomy.
Yes, and the age limit if the patient is 12 years.
Okay. So,
yes, go ahead. Yes, تفضل.
For cricothyroidotomy, it's contraindication in patient below age of 12 due to undeveloped cricothyroid or cricoid cartilage. So it's not an option for that age. We will go directly for tracheostomy or jet ventilator support. It's not an option to use the cricothyroidotomy. That's it.
Okay. Thank you so much, Dr. Muhammad. And now we can move to our next presenter, my colleague, Dr. Mishal Al-Numeri. You can share your slide, please.
السلام عليكم.
وعليكم السلام ورحمة الله.
الصوت واضح، الصورة واضحة إن شاء الله.
واضح بس ممكن تسوي فول سكرين.
أوكي إن شاء الله. إن شاء الله كده تمام.
Yes.
السلام عليكم. Good morning everyone. My name is Mishal Al-Numeri. I'm a trauma and acute care surgeon working at Noor Specialist Hospital in Mecca. I would like to thank you everyone for attending today, and I would like to thank IMSA for giving us this opportunity to make the world more safe. My topic, it will be about thoracic trauma. I think it is one of the fun topic for the trauma. My objective from this lecture today, apply ABCD, Principle of Management in Patient with Thoracic Trauma. We will repeat the same thing what was talked earlier by my colleague and my friend, Dr. Mohammed Mirza. We will recognize the important life-threatening injury in a patient with thoracic trauma. And finally, we will evaluate the case scenario. Okay. So let's make it a general talk. Thoracic injury, it's a common in-blood trauma and penetrating injury. To be honest with you, this is a benign injury. It's not a malignant injury. Why I said that? Because about 60% of thoracic trauma, it's with conservative management. It's go with conservative management, and you can save the patient with conservative management also, all the time. There is a percentage, about 20%, you need to do some intervention, and that intervention, it will be like easy, maybe chest tube. And also after that, you can follow up the patient. The dangerous percentage is about 10 to 15%. It's at that time you need to interfere with that cases. So we are talking about benign injury, not always, but it's common. So I would like always to start my topic on thoracic injury to show the dream X-ray for any patient. I think everyone who would like to have these X-rays. I like to start with this and make a comment how to read the X-ray. I know everyone had his own technique, and sometimes we are missing something, and we go back for that, and we are going to assist the patient, and we forget to assist the hemothorax or pneumothorax. I would like to share my technique and my experience how to read the X-ray. I know the ATLS protocol there is talking about airway ABC's technique, but my way, I think it's simple. I can use it every time. It is called rule of circle. So just remember this shape. It's look like a circle and complete the circle. So start from the top. It's a trachea. Is it centralized or not? Okay. Then go for the mediastinum. It's widening or not. So we will have the answers. Go then for diaphragm. Look for above and below the diaphragm. For above for diaphragm to assess for hemothorax, and below the diaphragm in the other side for air under the diaphragm. And go back again. So on the same side, going up, complete the circle. We will assess for pneumothorax, and don't forget to assess surgical emphysema in the soft tissue. And at the end, you'll go again back here. So remember, just to assess the bone. Okay, so remember, it's simple, easy technique. You remember everything. I hope it will be help you one day. So I will start by case scenario. A 17-year-old male involved in high-speed frontal impact motor vehicle accident. Airway is patent, obvious respiratory distress. Blood pressure is, I can say it is unstable patient, 90/50, with heart rate is 125, respiratory rate 40, and glaucoma score is 14. I know it is a virtual meeting. I think you can share your thought, your answer on the chat, but I can give the question and answer in the easy way. So just remember, when you are dealing with any trauma, forget about age, forget about anything, forget about yes, it's mechanism is important, but remember, your life, the patient life is dependent on your ABC, as Dr. Mirza said. Remember, forget about any specific side injury. Always remember ABC. So I think in this case, we should start by airway, assess the airway, is it intact or not? Then we will go for breathing. So what other investigation or examination we should see? Any thought? So I will continue. So what life-threatening injury may one discover in the primary survey that could account for the patient clinical situation? So unstable patient, what is your thought in this case in the breathing? So always remember, there is life-threatening and non-life-threatening injury. What I would like to target here in my topic, if you have life-threatening injury like tension pneumothorax, tension hemothorax, or open pneumothorax, you need to interfere directly. No need for go and jumping to C. Unless you have, yes, non-life-threatening injury, you can go and request some investigation, jump to the other C, B, and continue C and E, and continue your assessment. But in life-threatening injury, I think in this case, you go for ABC, and you cannot jump from B until you interfere with your P. So what next step in the evaluation and treatment is in management? So unstable patient. So we need more information about examination of the chest. So patient complaining of profound shortness of breath, and he is asking, I cannot breathe. Can you sit me up? Oxygen saturation is 89%. Cervical collar embrace, as I mentioned, it's ABC. Don't forget it. Once you assessment C, airway, and C, you need to, don't forget, once you open the neck collar, remember to assess the trachea. So in this trachea, the trachea was shifted to the left side. So when the trachea is shifted to left side or the opposite side, this means there is something tension in the other side. We don't know, is it pneumothorax, it's hemothorax? So this is the question to be answered by your exam and by your assessment. So we would like to assess the breathing sound on the right side, which is absent on the right side. So still, there is one more question to be answered to give you the direct direct diagnosis. So we are talking about unstable patient with trachea shifted to the left side and absent breathing sound on the right side. So we are in two things now, two diagnoses, and it's a critical diagnosis. Either we are talking about hemothorax, which is tension pneumothorax, or a massive hemothorax. So how we can assess and differentiate diagnosis for this case? I think everyone agree with me. It will be what? Sorry. So I think it will be, everyone will be with me asking about percussion. Okay, so it is important thing to do in these cases to identify what is the diagnosis. So by the percussion, it was hyperresonant. So I think in this case, we are dealing with what we can call tension pneumothorax. So what is the most likely diagnosis? As I mentioned, tension pneumothorax. What is the appropriate technique to manage this patient condition? So how we can manage this patient? It's same. Remember, I don't want to be a master in chest tube or any thoracic maneuver here. Just remember to go to the basic ABC. So before going to the chest, assess his airway. Okay, is the airway stacked or not? Neck collar is in place or not? Then remember, yes, in the breathing, you should do some assessment. So this patient, he had a tension pneumothorax. So what is the specific management for tension pneumothorax after ABC? So the answer is we need to release the tension. How we can release the tension? So we have, I think you will agree with me, it will be like needed decompression. Yes, correct. It's a needed decompression. My idea in this presentation, just to update you, where is the site of needed decompression? I know some of you will say yes, it will be in the second intercostal space, mid-clavicular. Just it's important message. There is a new update about for ATLS. I think it is 10th edition. Sorry if I was mistake, if I was wrong. But it's changed to needed decompression at fifth intercostal space anterior to mid-axillary line. It will be in the same side of chest tube applied. Vital signs improved. There was a gush of air. So just remember, we apply the needed decompression, gush of air is going out, and the vital signs improve. So what is the next step, important next step in this case? To continue the management, always don't forget to apply a chest tube in this case, because if you apply the needed decompression and it's look like as an open pneumothorax now, so you need to apply a chest tube to prevent another pneumothorax to be formed or a tension pneumothorax. Okay, what alternative management strategy can you use? There's another alternative management rather than needed decompression. Sometime I know you cannot find a needle to be inserted in the same area. You cannot find wide gauge needle or syringe. So what alternative management? So to be honest with you, I never used needed decompression. I'm using what we call finger thoracotomy. It is on the same side of anterior to fifth intercostal space mid-axillary line. It is safe. It's the technique. It's as you are applying a chest tube. You will open the skin, open the fat, fascia, and insert your finger through the pleura and doing sweep to identify is there any line attached to the pleura or not. Okay, so once it is safe. Why? Because by the needle you can hit the lung and cause more bleeding and maybe cause also an pneumothorax. But by this technique, I think it is safe in unstable patient, and it is wide opening and it can help you to drain the air or drain the fluid like blood. So this is a safe, fast, and you cannot, you don't need any resource like a needle here. And after that, you can use the same wound to insert your chest tube. So just remember this a technique, simple technique, and also it is easy and flexible. Just remember to use it, okay, one day, okay? What are the difference clinical presentation between attention pneumothorax, open pneumothorax, and hemothorax? As I mentioned, it's look like as same, like tension pneumothorax and hemothorax, massive hemothorax. It's same, but it will be differentiated by percussion. Open pneumothorax, it will be by there is a wound, sucking wound, and air coming through the wound. So how we can manage? So I would like to share with you one of what I can say it is one of the best video. Sorry. So this is a patient of stabbing and with this finding. So how we can manage this patient? Okay, I will repeat it again.
دكتور مشعل بس إذا ممكن الفول سكرين فيو توقف إذا ترجع.
طيب you want me to open the full screen or close the full screen?
أيوة لا لأنه توقف الآن إحنا ما بنشوفها
okay,
full
okay.
screen.
Sorry. Just a minute. Thank you, Dr. Sam.
ممكن تسوي ستوب للشيرنج وترجع
Yeah. Okay.
الآن هذا بيعطينا الفيو حقك أنت مطلع اللي هي السلايدات الثانية. أيوة
so
كذا أوكي.
Now, okay?
Yes, okay.
Okay, thank you. Sorry for this. I'll repeat it. As I mentioned, it's one of the best video I had. So this is a case of stabbing on anterior to axillary midline. Sorry, mid-clavicular line. So you can say it is patient look like unstable patient. Yeah. So what is the management here in this patient? With the wound, air and fluid coming from and blood coming from the wound, how we can manage this patient? Okay, the same thing. Don't forget, it's ABC. Don't think about the chest. Just it's by simple technique you can save the patient. So what I want from you to know, it's simple procedure you can do it and can save the patient. So in this case, you need to close the wound and not close so tight, and you need some what we call 3 valve or 1 valve, sorry, occlusive dressing. So let's share this thing. So to be honest, they are out of resource, so they are using a plastic thing, okay, and it is not the usual thing. So you can put anything like plastic, any plastic or anything you can apply on the wound. It's simple thing, okay? Don't think to apply a new plastic or something. Any plastic, you open the NG tube or something, you can use the NG tube plastic coverage, okay? And they are trying now to make the valve, 1 valve, by closing all 3 sides and keep 1 open. Okay, can you see there is a valve here? It's open here. Okay. Is the screen share is clear? Dr. Isam, is the slides clear now?
Still, but it is not full screen. So
Okay.
again, you have to do unsharing and share it again.
Okay, now?
Yes.
Yes, okay. So as I mentioned, a three-side occlusive dressing, it is in the open pneumothorax. We need to form a valve, okay? If you can see here, there are 1, 2, 3, and a half. They are keeping this open area. This is to let the air escaping, sorry, from this area. And once the patient had his inspiration, so the air cannot go through the wound. And always don't forget to apply chest tube in these cases, okay? So another case, it is a 43-year-old male involved in high-speed frontal impact motor vehicle accident. The vital signs respiratory rate is 20, heart rate is 110, blood pressure is 1060. So always remember, is it a life-threatening or non-life-threatening? Do I have time or I don't have time? Do I need to go for imaging like the previous case? We didn't go for X-ray before doing our needed decompression. Do we need to go for X-ray in this case or not? I think by this vital, yes, I can say it is partial responder depending on the fluid and assessment. So I think we can have some time to continue his assessment. So a patient complaining of shortened breath, saturation is 98. So it's 98 is great in trauma patients. Cervical collar in place. Trachea, as I mentioned, it's not deviated anywhere. Breathing sound decrease on the right side. Heart sound is normal. Why we are asking about the heart sound? Just remember, heart is important as a lung. Okay, this is an important organ in the thoracic cage. So we need, in unstable patient, we need to assess the heart. Is it muffled or not? But in this case, it's normal. So breathing sound decrease on the right side. So what other investigation we need to do? Trachea is not deviated, breathing sound is decreasing on the right side. So I think this is case we need to do a chest X-ray. So as I mentioned, repeat it again, how we can assess the X-ray, like a circle, trachea is centralized. This time it's look like it's wide. I don't know why, because of maybe a line is not clear here. So it's giving a false message. It's a wide mediastinum. We'll go down, we'll assess the diaphragm. It's clear on the left side, but it's not clear on the right side. Maybe it is hemothorax on the right side, no air in the diaphragm. And going up, yeah, it is a line shadowing is not clear on the right side. So maybe we are dealing with a hemothorax in this case. The lung, I think this is a lung, it's collapsed here. But the good thing is trachea is centralized. So going up, no surgical emphysema, and the bone is clear. The ribs is no fracture in the ribs. So what we are dealing with now, patient is look like an partial responder with decreased anterior right side, and he's tachypnic and tachycardia a little bit. So I think everyone agree with me. The patient, we need to assess, do one investigation or assessment. I think we'll go for percussion, but percussion was dullness on the same side. So what are we going to do here? What is the best management in this case? Yes, I know a lot of people go for chest tube, but I like to go. Don't forget, ABC, then your chest tube. So yeah, as I mentioned, don't forget your ABC. So this patient, we are dealing with we are talking about hemothorax. It may be massive hemothorax, okay? Massive hemothorax, you need to continue your assessment. It is a teamwork. It's you need apply IV line, and you need to prepare the blood for the patient. I know sometimes you are working in a rural area and you don't have type and cross-matched blood to be transfused for a patient. So in these cases, remember to you can use something to collect that blood from the chest, and you can use it again, what we can call it for auto transfusion. Okay, so in this case, thoracostomy tube was chest tube was placed and give you 600 of dark blood drain. So it is a 600. It's about 1.5 unit. So it is too much. So just to mention, if this patient you don't have a facility to prepare a blood for this patient, so you can use this auto transfusion. And I would like to recommend everyone who's working in a rural area and out of blood bank product. So just remember to prepare your unit by this thing. It's cheap, it's not expensive, and you can collect the blood and you can transfuse direct. Unless you have suspicious of bowel injury or something, this is the only contraindication to use it. Is it if there is a clot in the if there was a clot in the auto transfusion? Is it a contraindication? No, because there is a filter and it will be prevent any clot to go through the blood transfusion. So what are the indications for operation in a patient with traumatic hemothorax? So this is a question every one of my residents, they are ask me. So Dr. Michel, we apply a chest tube and we are not happy about chest tube. There is a large amount of blood. Patient sometimes he's stable, unstable. How you can assess your patient and you take a decision for thoracotomy in this patient? So I know, to be honest with you, it is a challenging case if when you have a patient, unstable patient, or you decide to take the patient for thoracotomy because two reasons. Some of us, they don't have the expertise to do a thoracotomy, and some of us, they don't have a facility to do a thoracotomy, like they don't have the set for to do a thoracotomy. So I recommend it should be done by expert general surgery in thoracotomy, or to be done by a trauma surgeon. If you don't expert in the thoracotomy, I think you will not benefit the patient. So I recommend everyone, if you are working in a rural area, just be expert in thoracotomy because one day you need it. How you can be expert? Just try to work with a trauma surgeon. You can work on American first or on animal, and try you to be with a trauma surgeon. You will have, if you did about 10 thoracotomy in your life, I think you will be an expert in thoracotomy. But I don't recommend, if you are in rural area and you are not expert in the thoracotomy, I prefer not to do that because it will be difficult for you for opening and closing and assessment and management during this. So what is the indication? Indication is different, really. It's depend. What I can say, it's depend on the patient situation. Either patient stable or unstable. So if the patient unstable, yes, it is one of the indication to do a thoracotomy. What other indication? It's depend on the amount and rate of a hemothorax. So amount, it's about depending on the first, once you apply your chest, if it is more than 1.5 liter, so I think it is an indication. But remember, if you have 1.5 liter drain from the chest and also the patient is stable, I think it is, you can judge your decision and you can change your decision depending on the patient because the patient is directing you, not the amount, okay? If the patient is stable with 1.5 liter of blood, yes, I know that it's just in the chest, it will be about 300 is collecting. It's not drained until now. But observe the patient. If still the drain is going about 100 liter or 200 liter per hour, yes, it's an indication, even the patient is stable. But if the patient unstable with drainage of about 1.5 liter, yes, this is one of absolute indication for thoracotomy. Yes, if it is not 1.5 liter, but you have a rate of about 250 per hour, so it's about 1 liter in 4 hours, you can assess this patient if it's a patient stable or not. If the patient is stable, I think there's rule for interventional, radiological interventional by our colleague on vascular or radiology to assess the from where this injury. What restrictive measurement should be undertaken in a patient with a massive hemothorax? As I mentioned, don't forget about ABC. Don't forget about airway and fluid and blood and cross match for this patient, and auto transfusion always. Important question. So we applied system in this patient, and there was about 600 blood. What test would you perform to follow up during the secondary survey? If you remember that X-ray earlier, there was a hemothorax on the right side. We applied chest tube, and we request a chest X-ray. This is what we should do in the follow-up in the secondary survey. Don't forget, if you apply chest tube, second thing to be done, chest X-ray. So this is just to say with the same patient. If you can see, yeah, I mean, this time earlier we thought it's widening, but it was not widening. It was collapsed lung and looked like as lung contusion. And lung is fully expanded, our tube in place. Yes, I'm not happy about one thing here in the X-ray, and it's in purpose I put this X-ray because of the hole. Okay, I like to see the hole inside the rib, okay, not outside like this. Okay, so this hole always remember to assess your tube, is it kinked or not, and the hole. There's two type of chest tube. There is one hole and two hole, and assess your tube before you insert. If it is two hole, so this is the first one. What is the second one? So always remember to assess your hole. Where is the hole of the chest tube? Is it inside the chest or it is outside? Because by this way, yes, it's you drain the chest tube, but the hole in the chest, by the end, it will be end by surgical emphysema. Case progress, vital signs, blood pressure 110/70, heart rate is 90, respiratory is 12, oxygen saturation is 99. So I will go fast through other injury. The other injury for me, it is not critical, not like hemo and massive hemothorax or tension pneumothorax. The other, it can be managed. It's simple, it's easy. Yes, I know it is when you call like blunt cardiac injury, everyone is jumping. Oh, we have a cardiac injury. No, it is simple thing, okay? Not simple as I mentioned, but you can manage, okay? For me, I think the most important life-threatening, it's two, tension pneumothorax and massive hemothorax. The other you can manage. So simple pneumothorax, it's managed by conservative, or you can apply chest tube. Hemothorax, as I mentioned, also small amount of hemothorax, you can observe it. No need to put a chest tube. But if you have a massive, you need to put a chest tube. Just remember. Sorry, I will talk about that after. If you have a flayed chest and pulmonary contusion, what is a flayed chest? Flayed chest is ripped in two and more consecutive ribs. So you have abnormal paradoxical movement of chest wall. So what is the management if you have this thing? So remember, it's ABC, and it should be managed by, if anyone think, it will be should by pain management, because the pain is too severe to be tolerated by the patient. And always think to be justified in your IV fluid. So pain management and IV fluid, okay? So what is the management? It's always ABC, supplement oxygen. So in pulmonary contusion flayed chest, you need supplement oxygen, pain control, and recognize the potential for respiratory failure. Next is blunt cardiac injury. So what is blunt cardiac injury? Blunt cardiac injury divided to two. One with cardiac tamponade or no cardiac tamponade, okay? So why I mentioned it's a cardiac tamponade or non-cardiac tamponade? If you can see this echo, okay, it is a part of fast now, extended fast. You should assess your cardiac window from the sternum and assess if there is a fluid or not. So this is a kind of blunt cardiac injury with cardiac tamponade. So what is the management? It's always ABC, okay? If the cardiac tamponade patient is stable, you can observe the patient. But if you cannot, like patient unstable, and can you rule out all the threatening injury, and the patient is not improving. So this is time to interfere and to do needle pericardiocentesis. Sorry. Where is the site? I think everyone should review how to do it. This is from sternum directed to the nipples, and always remember to assess your ECG for any change. So if it is, you rule out everything and you suspect of blunt cardiac injury, non-cardiac tamponade type. Okay, so how you can rule, Mike, a cardiac contusion? Okay, how you can rule a cardiac contusion? So the patient is complaining of chest pain, and the patient look like as unstable. How you can rule out a cardiac injury or not? I know some of them, some of you thinking, okay, I will call cardiac surgeon. Unfortunately, even in the tertiary center or a trauma center, sometimes it's difficult to call the cardiac surgeon to interfere with you. So you need to do your primary survey and do your assessment. Is it is it the case of cardiac contusion we are talking about in this case or not? So I would like to do what I prefer to do, two investigation. One is ECG and cardiac enzyme. So if you did an ECG and you find what you can here, the finding is ECG change. What ECG change you can find in a cardiac injury, contusion in the cardiac injury? I know some of you will go, okay, I will find ST elevation like MI. Sorry, I can't say that, it's wrong. You will not find ST elevation unless the patient is unlucky and the trauma is hitting one of our coronaries, and it is, yeah, I can say it is low percentage to hit one of the coronary and cause a cardiac injury in this case. So the finding ECG, it's always arrhythmia like SVT, atrial fibrillation, any abnormal finding in the ECG, like arrhythmia. We are not talking about C elevation. We are not talking about widening. We are talking of arrhythmia. So also it can direct you to find cardiac enzyme, CK-beta-alanine. If one of these is positive, you can repeat the follow-up of this patient. If still not improving, I think it's time to call the cardiac surgeon. So one of the injuries is cardiac aortic injury. As here, this is aortic knob. If it is absent and the patient is unstable, you should think about aortic rupture. I can add one important information. If you have suspect of aortic injury, aortic rupture, and you find a hemothorax on the left side, what is the management? Always ABC. And if it is a patient stable and you find a hemothorax on the left side, what I prefer, don't put any chest tube, because if you apply a chest tube, it will be like a hell. It will be like massive bleeding, and it will be not controlled. Unless the patient he's unstable and you are suspecting of aortic rupture, so I think you need to apply chest tube and transfuse blood and transfuse the patient to a vascular surgeon who can do an interventional management for this patient. And sometimes, if you don't have a vascular and interventional, you will go for thoracotomy and try to do your best. So I will not go for how to apply chest tube. Yes, this is a landmark for, you can see, this is a needle decompression. I like to keep this image always to remember, it is not the new position. The new position on the same side of the little finger here. And I don't like to do a needle. I like to use my finger in such cases. I hope you enjoyed this presentation. Thank you, everyone. And time for questions.
Thank you, Dr. Mishal. We have some of the question in the chatting. They mentioned here regard we should look to see the GVB needle in the second intercostal space by Dr. Yasin Al-Hussein regarding valve technique. I don't know, but
we should look to see the GVB needle. I think he was commenting on my lecture during the lecture, but yeah, I think he's do differentiate between the hemothorax or pneumothorax, because the GVB, it will be like visible in a pneumothorax, but it's not visible in hemothorax because the blood is all drained in the chest. So he will be like a hypovolemic shock. And yeah. What is the question and answer? Low voltage, if you have a low voltage, you can think about cardiac tamponade, to be honest with you. But in the cardiac injury, I don't think we have a low voltage ECG. It's always about arrhythmia. It's one of the important MCQs for MRCA or some MRCs or something, any exam. So finding an ECG, it's always arrhythmia. Unless, as I mentioned, he's unlucky patient and the trauma hit one of the coronaries, you will find a ST elevation.
thank you. We have raised hand by Dr. Deboa. Will allow you to talk. You can unmute your mic and you can ask your question, please.
Yeah. We have one question about. Yeah, sorry. Yeah, go ahead, please.
How can we manage when we have an open pneumothorax with an object like sword? Can we remove the object or we need to do something first? Thank you.
Yeah, thank you very much. It's great questions. Always, if you have stabbing, we will stuck with the same ABCs. Yes, it's one of the critical decisions sometime for me, and I think it is a safe answer for such case. If the you need to do an X-ray, is it in the chest or it is on the skin and subcutaneous tissue? If it is penetrating, and I think this is what you are talking about, if it is penetrating, I think you need to go for thoracotomy, and you can do it under vision to remove this object, because it can hit the lung, it can cause bleeding. If you have a thoracic surgeon with you in your area, I think some of them, they can do what we can call a thoracoscopy. They can apply their port side and they can remove the object under vision, and they can assess 2 area or 3 area, assess the lung, assess the pleura, and assess the assess the wound side. Is there bleeding or not, to control it? So in the area of rural area and you are expert in thoracotomy, I think this is one of the indication to do a thoracotomy and remove the object under vision, because it can hit the lung, it can hit the pericardium, heart, and you cannot remove the object blindly, because the patient, he will be bleeding and you will lose the patient. I hope it will be clear.
Okay. There is one more question. Need more explanation about the finger method, please.
Yeah. Yes. I think it is one of the new technique. It's not a new, but last 2-3 years we are shifting from needle to finger. It's a simple procedure. Just remember how you choose your site for chest tube. It's same 5th intercostal space, anterior to mid axillary line. So what we should do next, the same procedure to apply open the skin, subcutaneous tissue, and go through by puncturing the pleura, and you apply your finger inside and sweeping around the pleura. And once you apply your finger and take it out, there will be 2 findings. Either you will find a gush of air, or you will find a hemothorax or blood. So this is the same. And what I prefer nowadays, we can open in YouTube and just Google it and follow any video on YouTube. It will be so easy, so simple, and you can save the life of the patient.
There is one more question. about creating the valve. Is it applicable to both tension pneumothorax and open pneumothorax, or it is just only for the open pneumothorax? اللي هي creating the three-way valve.
Yeah, I think it is not for tension. It's not absolutely. It's not for tension pneumothorax. Tension pneumothorax, it's the management by finger thoracotomy and chest tube. 3 valve. So 1 valve. It's for an open pneumothorax. If you found open wound and sucking air in and out, this is a time to apply a gauze and 1 valve technique.
Okay, thank you so much, Dr. Mishal. And I think we can move on with our next presentation. Our next presentation will be by my colleague, Dr. Basim.
Assalamu alaikum wa rahmatullah.
Wa alaikum assalam wa rahmatullah. You can start sharing your screen. Full screen.
Is it clear?
Yes, clear. You can go. Yeah.
طيب. Assalamu alaikum wa rahmatullahi wa barakatuh. Sabah khair. Good morning, everybody. It's really, I'm honored to be here, hosted by the IMSA and Dr. Assam in this trauma lectures. As you guys, I'll just go ahead and start. As you guys saw before, always Dr. Mirza presented about the briefing, or and then Dr. Ajay will present the airway, and then breathing, airway and breathing, and now we'll be talking about the C. So always in trauma, go by algorithm. The whole management in trauma is doing systemic algorithm. It's not difficult, it's not complicated. It's just like you need to go systemic, and you and your patient will be safe. I'll be talking mostly about the C, which is, in other words, the shock. You have the control, or I do? Okay. So I'll start with the case. This is a 30-year-old male patient involved in motor vehicle collision, presented to the emergency department agitated and in pain. His vital signs: heart rate is 110, blood pressure 100/70, and oxygen saturation 92 on face mask. He has a major abrasions and seatbelt sign on his abdomen, and there was obvious deformity on the left side. As an ER physician or a surgeon or a GP or anybody involved with the trauma, what would be your approach? As always, we always start the same, no matter what was the trauma mechanism, no matter what was the injuries expected, no matter what was the clinical condition of the patient, we always start by airway, breathing, and circulation, ABCs. So this patient, he has 92 on oxygen face mask. It is kind of acceptable. He is a bit agitated and in pain. After you assess his airway and you make sure that it is patent, you can proceed with the breathing and chest evaluation. And Dr. Michal presented great talk about the chest trauma. And then you go for C. And you evaluate whether this patient in shock or no. And as you can see, he's tachycardic. He's on the lower part, on the lower border of blood pressure, and you can see he has a deformity in his left thigh, which means he lost a lot of blood. And we'll talk about how much you can estimate by looking at their clinical parameters. You can estimate how much those patients have lost. So, as any scientist, if you want to treat something, you have to know it, you have to define it. And to define a patient that he or she in shock, you have to know what shock is. So basically, in very basic words, this is shock is an abnormality of circulatory system that result in inadequate perfusion, tissue perfusion, and tissue oxygenation. So there is no enough blood carries oxygen to the different parts of the body, and this will result in consequence with low hemoglobin and low perfusion, and this will be on consequences result in low production of these organs, whether we are talking about like vital organs like the heart, the brain, and kidneys, or other organs like the skin and intestine. So in patient with shock, the most important thing that you have to recognize that this patient in shock. If you recognize that this patient in shock, the management and the subsequent steps or the following step will be very easy. So during management of any trauma patient, there's few questions you should ask. Is my patient in shock or no? If he's in shock, what type of shock? Like why this patient in shock? What put him in shock? And what I can do about the shock? Like how can I treat it? Whether I have to give blood, I have to give fluid, I have to do something, I have to take this patient to OR, and what is my management effect? If I give fluid, is this effective or no? I have to do something else. I have to put more fluid in, or I have to do intervention now. So if you ask yourself these questions, I think your management to the trauma patient, or you are managing a trauma patient in a perfect way. And last question, do I need to do any further actions? Like if you are giving patient, for example, blood and blood products, is my management effective, or I need to do something else? I have to take this patient to operating room, or I have to take him to somewhere else where I have to stop bleeding. So basic things before you start with dealing a trauma. If you have the privilege of time before patient arrival, you have to be prepared. Like anything in life, preparation is the key to success. If we were prepared to deal with the trauma patient, I think the chances he or she survive and have a good or great outcome is way better than if you receive the trauma without a previous notification. In some countries, I know they have a system where they can know about any trauma patient coming. So if you knew about a trauma patient coming to you, it will be very nice to activate your trauma team to get the expert in the trauma, for example, a trauma surgeon or general surgeon, anesthetist to protect, to secure patient airway, to get some X-ray technician. So if you needed an X-ray, it will be available and ready. It will be nice to get your equipment for chest tube, for intubation. You will be very nice to get your environment ready, blood products, medications. So the more you prepare, I'm sure you guys all know, the better outcome the patient will have. And finally, your standard precautions and BBE. Your safety is a priority. If you are safe, your patient will be safe. And this is, I'm sure, general principle in life as well. So how can I tell if my patient is shock? As you can see, there is multiple classes or 4 classes of shock, and looking at the patient, looking at their vital signs, you can estimate how much they lost blood. Usually, I look at 5 parameters, which is all clinical. You don't need to do complicated or sophisticated blood work. You can look at their heart rate, their blood pressure, their pulse pressure, which is the difference between systolic and diastolic blood pressure, and in addition to the evidence of end organ perfusion, which is the urine output, which indicate how much blood going to the kidneys, CNS, which indicate how much blood going to the brain, because those are the last two organs lose their blood supply. If you have less blood going to those organs, this means the patient lost a significant amount of blood to a degree where those two organs are affected. In addition to the respiratory rate, which sometimes can be affected by direct thoracic trauma. So looking at their 5 parameters, you can tell how much they lost blood. And I always go by percentage because blood volume is different or differ from a patient to a patient based on their weight. But percentage wise doesn't lie. If you lost 15% of your blood volume, this means you lost 15%, whether your blood volume is 5 liters or 4 liters, or in pediatric less than that. And I'm sure you guys all know we calculate the blood volume 80 ml per kilogram. So if you have a 70 kilogram patient, they have around 5.6 liters. And if they lost around 750, this will put them in class 1 shock. 750, almost like blood transfusion. And you like their vital signs, mostly they will not change. Maybe they will have only little bit of tachycardia. And as you lose more blood, the heart rate will be increasing. Blood pressure will be initially compensated, and then they start to be hypotensive. The blood pressure initially will decrease because of the diastolic blood pressure goes up, and then it starts to decrease, and the urine output starts to decrease as well, as less blood going to the kidneys. And for the brain, they have a little bit of anxiety, agitation, and then they go into coma. And if you assess those vital signs and vital organs, you will tell which stage your patient is in, and you can start your management. Nowadays, this is maybe an old recommendation. Nowadays, most of the recommendation says early blood transfusion is associated with better outcome. So if you started crystalloid, if you gave a patient crystalloid and he didn't respond, go ahead and start blood, either whole blood or packed RBCs, because this is associated with better outcome. So I recognize that my patient in kind of shock based on the vital signs I logged. What type of shock? Like what the cause of his shock? Think always hypovolemia, hypovolemia, hypovolemia. In any trauma patient, hypovolemia is the main cause of shock till proven otherwise. Over 90% of patients, they come hypotensive and in a shock due to bleeding. So look for source of bleeding. And if you couldn't find any source of bleeding, start thinking of non-hemorrhagic cause of shock, whether tension pneumo, cardiac tamponade, and Dr. Mishal enlightened on those, or septic in late patient who present late, or neurogenic with a spinal cord injury. So how I can recognize where this patient is bleeding from? Very simple maneuvers, very simple things. Basically, clinical examination. As you can remember, we don't, like, the whole body has few cavities where they can lose blood in those cavities to a degree where they can go in shock. Chest, one of them, abdomen, pelvis, long bone, femur, tibia, and always remember outside bleeding. So for outside bleeding, I'm sure physical examination will be more than enough to recognize. So scalp bleeding, posterior scalp bleeding, those two areas you can pick by physical examination. Chest, abdomen, and pelvis, your physical examination will give you a great help. Auscultation, percussion, palpation will tell you if those cavities are filled with blood. Also, you can use, if time permit and facility permit, to do a quick portable chest X-ray, pelvic X-ray, or PAS. You can use those, and in combination, if you use these three methods, I'm sure you can diagnose over 95% of bleeding and where they're coming from. So what we can do, obviously, stop the bleeding. This is the basic task you have to do, and your patient will be safe. Of course, as you guys were told in the initial presentation, when you have a patient securing airway, breathing, and circulation, in addition to stopping the bleeding, you have to replace your loss. So securing IV is very important, and this is usually done simultaneously with the initial assessment. But when it comes to management of shock, stop the bleeding is a basic task you have to do. Few things you can do, whether you are in highly sophisticated center or in a primary care center or very simple center. Direct pressure is the best old way to stop most of the bleeding, whether you have active bleeding to externally, or if you have wound and bleeding inside. Hemostatic agent, if you have, you can apply it directly. Splinting, in terms of fracture, we always recommend splinting, and this is basically will realign the broken bone and decrease the blood loss and improve and decrease the patient pain as well. Tourniquet, if you have fracture or open wounds, you just go proximal to the bleeding point and use a tourniquet or anything proximal to that to occlude the blood vessel, and this will decrease the bleeding source. Embolization, if you have the facility of angio embolization, and usually we do that in retroperitoneal bleeding, abdominal bleeding, pelvic bleeding, mostly, and patient is stable enough to go there. And if it didn't fail, always the operating room is the last resource. You have to go, and you can't stop any kind of bleeding. So some pitfalls in trauma where we can miss. Vascular access is very important. You have to get vascular access for any patient, because you want to replace the blood loss you have. So vascular access is very important. Fluid resuscitation. Patient lost blood, you have to replace it, whether with fluid, crystalloid, whether normal saline ring lactate, no much difference, or blood. Blood transfusion, as I said, and prevent hypothermia. Hypothermia is one of the major things can cause devastating outcome, and always when we give blood, we have to warm it to prevent the hypothermia and consequences of the hypothermia. And always you have to monitor your response. As I said before, is my treatment effective? You have to monitor the patient response. You have to monitor their vital signs, and their urine output and their CNS level if you didn't intubate those patients earlier. And always keep in mind, too much is as bad as too little. You don't want to sink your patient in fluid, but in the same time, you want to give them the appropriate amount of resuscitation. This is why always reevaluate and reevaluate and reevaluate. Permissive hypotension is one way of managing patients where you don't want to normalize their blood pressure or their heart rate. You allow them to be on the hypertensive side, because if you put or if you normalize their blood pressure by giving them fluid till their blood pressure is normal, blood the blood vessel might rupture the clot with the normal blood pressure. So you want to keep them on the lower side of blood pressure, and in the same time to allow those clots to act. But in the same, and most importantly, you don't want to do that in patient with TBI or traumatic brain injury or head injury, because those patients hypotension will affect them in a negative way. And as we mentioned before, blood volume usually 70 to 80. So you estimate the blood volume of a patient and you replace it accordingly. And in pediatric age group, usually we use 20 ml per kilogram as a bolus. But in adults, usually they can tolerate just boluses, 1 or 2 liters policies, they can take it very well. So patients usually can be categorized into 3 categories. Somebody who bled and stopped bleeding, and those usually respond to your fluid resuscitation very quickly, and those patients will stabilize after a few liters of resuscitation, and they don't need any further actions, and this means the bleeding has stopped. Transient responders, those patients who are actively bleeding, but you are doing so great, or you're doing great job where your resuscitation exceeding the bleeding rate. So they are okay as long as you are transfusing blood to them. As soon as you stop, they start to bleed and show that they are hypotensive or in shock. So we call it transient responder. Those patients where you have to do something else other than only giving them fluid or resuscitation, but you don't have to do it immediately. You have a little bit of time privilege. Non-responder, where they have a major bleeding or they have active bleeding, and no matter what you do to overrate or give them blood or resuscitate them, the rate of bleeding is so high, and those patients where you have to interfere immediately and stop the bleeding source. So it will be very nice after few minutes of resuscitation to try to categorize your patients so you can resuscitate those patients and triage them to their next station. Again, in addition to that table I showed you about the effect of your management, you can always go back to your to patient scan, renal, vital signs, and CNS, and this is what we just went through a bit earlier. So what next? You give patient blood products and you categorize them. So you have to move on. You cannot keep resuscitating patients forever in the emergency department. So either patient responded and you have to move your next step of evaluation, i.e. You move to D and E, and after that whatever patient need, or you have to move to radiology for further investigation, whether you need to do CT scan or you need to do angio, and those patients usually for the transient responder, or you have to move to the operating room to stop the bleeding because you cannot stop it in the emergency department, and the rate of bleeding way more than what you can overcome by simple resuscitating or simple measures of stopping the bleeding. Thank you very much. And I hope I little bit organized our thoughts. Any questions?
Thank you, Dr. Bassem. The floor is open now for any question, please, from the attendee. If you have any question, you can just raise up your hand and we will allow you to talk so that
So somebody
the question and the answer.
Yeah, about FAST. So FAST basically stands for Focused Assessment Sonography of Trauma Patient. And you don't need to be a radiologist to do it 100%. It's all you need is a simple ultrasound machine. We look at 4 points to see whether the patient has free fluid. We cannot say this is blood or this is ascites or this is food content. We just say patient has positive FAST or negative FAST. And basically you look at 4 points, suprapubic, which is the simplest. And usually if patient has full bladder, it will be way easier to evaluate if patient has free fluid by seeing the black acoustic shadow. And then we look at hepatorenal angle, which is in the right mid-axillary line. And you look if there's any fluid between the edge of the liver and the kidney. And the third point between the splenorenal angle on the left side, again between the spleen and the kidney. And this is to evaluate the intra-abdominal fluid. I'm just saying fluid. You cannot say this patient is bleeding or ascites or food content. And the fourth point is the cardiac window or the cardiac shadow, where you evaluate if any pericardial fluid. And this is basically what FAST is about. And it's a 4 point. Nowadays, we do what we call extended FAST, which you look at the chest and if there is any hemo or pneumothorax. And this is what is called extended FAST. How about arterial shock?
I answered him that there is nothing called arterial shock.
Yeah, nothing. Maybe you mean pulse pressure? Arterial pressure. So arterial pressure.
If he can raise his hand, we would like to allow him to speak so that he can explain his question, please.
Okay, till he come up to speech. So does the management occur in pediatric patient? Usually for ABCs, it doesn't differ. Pediatric age group has a special consideration in their physiology and their anatomy. For example, when you intubate, when you do a chest tube or for chest and for abdominal organs. But in principles, it is the same. ABCs are the same with the pediatric or adult. In pediatric, the dosage, the transfusion, and all this stuff definitely will differ because of their age group. And I highly recommend to have a Persilo tape, which is like a kind of tape where it gives you a ready measure of blood volume, the common medication you use, and approximate weight of the patient based on their height and their age. We go back to the doctor who said arterial pressure.
I don't see any raised hand, so that I don't know where I can find him in this crowd. But if he can just raise hand, yes, Dr. Amado, allowed to talk. Yes, doctor. You can unmute your mic, please, and you can speak up.
Okay, good morning.
Morning.
Good.
I asked about you can say stop bleeding about arterial shock, about any shock, stop bleeding.
Mhm.
When we have about rectal arterial rectal, what we can do?
Retroperitoneum, you mean?
Vein, we have two venous vein with arterial venous. When
Which
we
part
have
of the body?
About the neck, the arteria cervical.
In the neck?
That we can, yeah.
Yeah.
Okay. So if you have a neck injury, most of the time venous bleeding is stopped by just simple pressure. Arterial bleeding in the neck, you have to be careful because you don't want to tie that blood vessel and you prevent blood flowing into the brain, right? So stop the bleeding by just simple pressure, direct pressure to the artery. But for neck in particular, you have to, or I highly recommend that you explore it in the OR where better lighting, patient sleep, and you have a proper instrument to control and repair the bleeding. Will this answer your question?
Thank you so very much.
No problem. So you calculate the blood loss, somebody is asking, based on the vital signs. So if you have somebody who is hypotensive and comatose, this means that he or she at least in grade 3 or 4 hemorrhagic shock. If somebody is only tachycardic, is maybe he's in class 1. So if you remember the classes and the clinical correlation to those classes, you can calculate the blood loss based on their weight. So class 1, we always say less than 15% of the blood volume, class 2, 15 to 30, class 3, 30 to 40, and class 4, more than 40%. And looking at the patient, estimating their weight, and you just multiply it by 80. So if you have somebody who's around 70 kilogram weight, you can multiply 70 by 80, and this gives you 5 liters. And if he's hypertensive, this means he lost 40%, say, or more than 40%. So he lost 2.5 liters or 3 liters of his blood volume, which is a very big amount of blood to be lost.
طيب, we have Galaxy A6 raising his hand. Will allow you to talk. You can unmute your mic, Galaxy A60. Hello, Galaxy A60. You can unmute your mic and you can ask your question, please.
Okay, so till he starts speaking, there is an interesting question from Dr. Huzaifa Ahmed. Is there a statistically valid relation between weight and the duration of surgery? Fortunately, we have Dr. Isam, and you might know him. Dr. Isam is one of the figures in the country in bariatric surgery. I will tell you what I know, like the relation between duration of surgery and weight, and Dr. Osam can enlighten this more. Definitely in trauma, you don't want to spend much time in OR, whether the patient is morbidly obese or in normal weight or cachectic. The whole thing in trauma laparotomies, you want to be there very quickly and very short period of time, just for damage control. You don't want to do fancy anastomosis. You don't want to do fancy laparotomy with Whipple or anything like that. You want to go, stop the bleeding, control the contamination, and you go back definitely later. The weight of the patient, we all know that when you operate on obese people, their risk of complications is higher than non-obese or normal weight people. So definitely there is relation between the surgery and the outcome of the weight and the outcome of the surgery. I don't know if Dr. Assam wants to add to this.
Thank you so much. No, nothing really to add as just what you mentioned. So because of the time, if we could move on to our next presentation. Thank you so much, Dr. Basim.
Okay, thank you very much.
So our next presentation will be by Dr. Al-Bara Kazim. Dr. Al-Bara, you can start sharing your screen and your presentation, please. You can go full screen. أيوة تمام.
Assalamu alaikum, everybody. It's an honor to be here with the great faculty. Thank you, IMSA, for this chance. I'm Dr. Al-Bara Kazim from Noor Specialist Hospital. Today, I will talk about the abdominal and pelvic trauma. It's one of the most important topics in trauma. Why it's important topic in trauma? Any trauma to the abdomen will lead to organ injury, intra-abdominal, that will lead to bleeding and eventually hemorrhagic shock. And this hemorrhagic shock, if not diagnosed, and this trauma, if not diagnosed in the proper time and treated in the limited time, will cause preventable death. So it's a common preventable cause of death. Our objectives in this lecture to classify the mechanism of injury or to classify the abdominal trauma according to the mechanism of injury and to know some about the anatomical region of the abdomen. We will know some tips about the assessment and diagnostic procedure. We will identify the patient who require surgical management or surgical intervention, and we will describe some acute management of the patient with abdominal and pelvic injuries. Here is the classification. We'll classify the patient after abdominal trauma according to the mechanism to patient with a blunt trauma, penetrating trauma, and combined trauma. Blunt trauma, we have many types of blunt trauma: compression, crushing, shearing, and all that mean of blunt non-penetrating trauma to the abdomen. Shearing, for example, like the inappropriate seat belt. The most common injured organ in blunt abdominal trauma is the spleen, around 40 to 50%, liver 30 to 40%, bowel 5 to 10%, and finally pelvis. Penetrating trauma, that means penetrating the abdominal wall, which is protecting the abdominal organ. We should ask ourselves a couple of questions. Is it stab wound or gunshot? Why do we need to ask ourselves this question? Does it matter in the management? In general management and resuscitation of trauma patient, that does not make any difference. But in terms of determination of patient need for operative intervention or an urgent exploration or not, and for the sake of the thinking of the which organ injured, yes, it's differ. Patient with the simple stab wound by knife to the flank is different than gunshot in the middle of the abdomen. Bullet is different than the pellet, which has more damage. Visible exit site also, it's important. The area between the entrance site of the gunshot and the exit site will have intra-abdominal or extra-abdominal organs, and that will lead you to think about organ injury and need to be investigated well and explored well. And the stab wound, also we have multiple organ injuries like the blunt injuries and more with gunshots. Combined injury, what do we mean by combined injury? We mean combined blunt and penetrating injury. The most common example is the explosion, the bump blast, which is combined of blunt trauma with the effect of bump explosion and penetrating injuries due to penetrating fragments. And also in the exclusion, we have the burn, thermal injuries, and the risk of thrown or falling from height. Let's have quick anatomical review. In abdominal and pelvic trauma, we have three regions. Peritoneal cavity, which is include diaphragm, liver, spleen, stomach, and bowel. Retroperitoneal or an extraperitoneal regions. It's not one region, it's regions or zones. It's classified, subclassified to three zones. Zone 1, which is central, which contain the main vascular structures, the aorta, vena cava, and the pancreas. And zone 2 will be on lateral on zone 1, both sides, which contain the kidneys, and right side, the duodenum and the ureters, and part of posterior part of the colon also. And zone 3, which is the pelvis. Injuries to retroperitoneal organ will lead to bleed as the intraperitoneal organs, but somehow it's difficult to diagnose. Why? Because of three reasons. First one, clinically, there is no clear peritoneal sign will appear initially after the injuries. Second, is not diagnosed by ultrasound easily, or the diagnostic peritoneal lavage or diagnostic peritoneal aspiration. Pelvic, the third anatomical region, we have the pelvic organs, rectum, bladder, and the structure, the vascular structure, and the genitalia. We have this sagittal cut of the abdomen and pelvis. In this area, we have the liver, the stomach, the colon, the mesentery, the small bowel. This is the intraperitoneal organs. This is the extraperitoneal zone 1. We have the pancreas, the duodenum, and we have the vascular, the aorta and vena cava. We have the pelvis here. This is the bladder. Small part of the bladder will be intraperitoneal. The majority of the bladder will be extraperitoneal in the pelvis and the rectum. This is the axial cut, will show also the peritoneal cavity and the retroperitoneal cavity. We have here the kidneys and the great vessels in retroperitoneum and the bowel in the intraperitoneal cavity. When it comes to the assessment, we mean the examination and the investigation. Examination, detailed examination is part of secondary survey to examine the patient from head to toe, and that means we will examine the abdomen and pelvis very fine. Inspect your patient carefully for any distension, any bruises, ecchymosis, wound, or penetrating object. Palpate for antenderness, guarding or rigidity, percuss and auscultate for bowel sound. Do not forget to examine the flanks, the back of the patient, and to do genitalian examination and digital rectal examination. In investigation, chest X-ray, pelvis X-ray, FAST, DBL or DBA is part of adjunct to primary survey. CT scan is after the secondary survey or adjunct to secondary survey. Other blood investigation, CBC or ABG, CBC to look for hemoglobin, ABG to look for the lactate, will help us in resuscitation. This, I think, it's part of C in primary survey. Once the cannula is inserted, the blood investigation is drawn. Let's see this chest X-ray. For trauma patient, this X-ray is showing the air under the diaphragm, which is a sign of hollow viscous injury. Let's talk a little bit about the ultrasound in trauma, which is called FAST, Focused Assessment Sonography in Trauma. This study will aim to examine 4 regions in the abdomen: the Morrison pouch, the splenorenal, the pericardium, and the pelvis. We are looking mainly here for free fluid. We are not looking at the organ themselves to look for the injuries. We are looking for free fluid. This is the Morrison pouch, this is the liver, and this is the right kidney. This is the Morrison pouch. We can't find the free fluid. The free fluid will come in ultrasound as a black color, like this one here in pelvis. This is the bladder, contain a black, which is the urine fluid. This is the spleen, this is the left kidney, this is splenorenal pouch. And here is the pericardium. This is the heart, the 4 chambers of the heart and the pericardium. We are looking to hemopericardium. Or this picture on your right side will show positive FAST, which is contain free fluid. This is the liver, this is the kidney, this is the black area called free fluid. CT scan. CT scan is sensitive, specific test in trauma patient. You need to take the patient, you need to select your patient, which patient indicated for CT scan, not all patient indicated for severe trauma. And you need stable patient because patient will be shifted to radiology department outside the emergency department. This picture on your left side has splenic injury and this area, which the arrow is pointed. No active flush seen in this cut. No liver injury. This is the kidneys and this is the pancreas. Very nice picture. No free fluid seen in this picture. See this study on right side. We have this liver injury. And spleen seems to be normal. And this dark area around the spleen is free fluid, most likely due to the liver injury. Here also we have some free fluid. This table is drawn from the ATLS 9th edition, which compared the diagnostic peritoneal lavage and the focused assessment sonography in trauma and the computed tomography scan. Main advantage of FAST and DBL in comparison to CT scan, we can done bedside rapidly, and it's sensitive for intraperitoneal injuries. It can miss both of these 2 studies, can miss the retroperitoneal injuries, diaphragmatic injury also. FAST is non-invasive and DBL is invasive procedure. FAST is operator dependent and can be masked by gas or subcutaneous air. CT is costly and time consuming and need to transport the patient to radiological department. Let's have a brief talk about specific common organ injured in trauma, intraperitoneal organ injured in trauma. We have the spleen. The spleen is the most common injured organ in trauma, in blunt trauma mainly. Splenectomy was indicated long time ago for any splenic injury. Nowadays, it's not indicated unless patient is unstable due to this injury or have an active bleeding by the scan. If you want to conserve your patient with a splenic injury, you should have something or conditions or criteria to conserve this patient. You should have stable patient. You should have patient monitoring available for 24 hours. You should have blood bank, blood products, operation room and surgeon available for 24 hours. Please do not just leave your patient in the ward without any monitoring or physician or surgeon assessment. And the patient should be free of concomitant intra-abdominal injuries requiring operation, which means if you are exploring the patient for example, bowel injury and you resect and reanastomose your bowel, do not leave injured spleen behind in the abdomen, especially if the patient is adult. Liver injury, which is second most common injured organ after blunt abdominal trauma. Most of the liver injuries nowadays is treating conservatively, non-operative management for it. When to take this patient for OR if you have unstable patient despite good resuscitation, or patient is transient responder to the resuscitation, which means it's during resuscitation he's responding. Once the resuscitation is stopped, he's deteriorating and being unstable. This transient responder most likely need an operative intervention. Or nowadays, liver injury is managing also by angiography and angioembolization. We have also the same conditions or criteria needed for non-operative management, that patient is hemodynamically stable and availability of all services, OR, blood bank, and surgeon for 24 hours. Operative management for liver most likely refer to be a damage control surgery or just limited surgery to control the bleeding by backing, and the definitive surgery most likely in a step surgery in the second laparotomy or even third laparotomy. In general, we're talking in abdominal and pelvic trauma. What's the indication of laparotomy? In blunt trauma, if the patient hemodynamically abnormal with suspicion of organ injury despite good resuscitation, the patient has free air, diaphragmatic rupture, peritonitis, or positive fast DBL or CT scan. Even in positive fast DBL or CT scan, if the patient is unstable, you can investigate more. You can wait more to see if the patient needs an operative intervention or not. In penetrating trauma, also hemodynamically unstable patient, we have free air, peritonitis, positive fast CT scan or diagnostic peritoneal lavage, or you have evacuation of intraperitoneal organs, like most commonly the omentum or the small bowel. What do we mean by damage control surgery? Damage control surgery and damage control hemorrhage came from after the World War II. Once the resources is limited in the war and the patients are unstable and tend to be very useful way, and now it's used in the hospitals also nowadays. Damage control surgery for unstable patient to control the hemorrhage and limited the contamination, and waiting for the definitive surgery or repair for the second surgery. For example, you have liver injury, we'll do just packing, examine the other organs, close the abdomen temporarily, shift patient to intensive care unit, resuscitate the patient, save him, bring him after 24 hours or 48 hours to re-explore him again, take the bags out, explore the abdomen. What's definitive surgery need to be done, that time will be done. Pelvic trauma is associated with the high mortality, 13 to 23%, and in some books with higher mortality above 30%, and significant morbidity also. In majority of the patient, they have massive zone 3 extraperitoneal hemorrhage that because of the unique structuring of the pelvis. It's on your left side, you will see very nice bony pelvis. But the problem is the great vessels and high vascularity of the pelvis. Any fracture to these bones may lead to vascular injury, which lead to hemorrhage, massive hemorrhage, especially if the pelvic fracture are unstable, which we mean the open book fracture, like on the X-ray on your right side. That may lead to instability and hemorrhagic shock. Assessment assessment, we have suggestion the pelvic trauma by pain, movement, structural instability, gross hematuria, peripelvic pelvic ecchymosis, rectal examination. You will find the rectal injury, prosthetic, high riding prosthetic position, the X-ray for the pelvis, and the examination of the pelvis, is it stable or no. Management of pelvic injury is returned back to the trauma survey, ABC, airway, breathing, circulation, and during the circulation, the C is also control of hemorrhage. You have patient with unstable pelvic fracture, you should stabilize to minimize this pace of unstable pelvis to decrease or control the bleeding. And this picture down, this is the pelvic binder to stabilize the pelvis. This is commercially branded pelvic binder. If you don't have this commercially binders, you should just go for the simple bed sheet as a binder to stabilize the pelvis. Always, always, always rule out abdominal hemorrhage, especially if the pelvic fracture is stable. Always look for intra-abdominal hemorrhage. If you have unstable patient with pelvic trauma, do your initial management and resuscitation, then consult the surgeon after you are doing your pelvic wrapping. If you have unstable patient with pelvic trauma or open book unstable pelvic injuries, and the patient also has an intraperitoneal bleeding, please go for laparotomy. Please go for laparotomy. If you examine the intraperitoneal organs by scan, ultrasound, or DBL, and there is no intraperitoneal bleeding and patient are unstable due to this pelvic trauma, go for angiography and angioembolization to control the pelvic bleeding. If you don't have angiography at this time or angio is failed to control venous bleeding, please go for pelvic backing. Do not go for laparotomy. Go for pelvic backing by small longitudinal suprapubic incision and back the pelvis from both sides around the urinary bladder to control the bleeding, and ask your colleague from orthopedic to fix the pelvis from outside. Thank you so much. Any questions? Any question from the audience? Dr. Assam, Dr. Mirza, you can take over.
Thank you. Yeah, thank you very much. Thank you very much, Dr. Albara. Now we will go to the next stage. Muhammad Udilli, Dr. Muhammad Udilli, are you with us?
Yes, good morning. I'm available.
Okay. Can you share your screen, please?
Yes. Thank you. Is
okay, please.
Okay, you can see it. Okay. Bismillah ar-Rahman ar-Rahim. Salatu wassalam ala Rasulillah. I would like to thank all the committee for and organizers to allow me to have this to be part of this nice webinar, and thank you for IMSA for giving us the opportunity to share knowledge with our dear colleagues from all over the world. Today, inshallah, I'm Mohammed Widinli. I'm a general colorectal surgeon in Security Forces Hospital, Mecca. We will talk today, inshallah, about one of the injuries that it is very commonly encountered during managing trauma patients. And the beauty of this injury per se, that it is very simple to manage, but it can save the life. The other way and the other drawback of this injury is that you might miss a small injury and the patient, usually it's when it's a major limb affected, then it's going to be life-threatening. Otherwise, the patient limb might be threatened after a couple of days. This is why you have to continuously evaluate your patient and anticipate the injury and treat it accordingly. Don't forget that the patient has small bones in his hand and feet that may be fractured, but unnoticed, because the patient will not express the pain that usually the conscious patient will express. So, injuries to the musculoskeletal system occur in many patients who sustain blunt trauma especially. They often appear dramatic, but rarely cause an immediate threat to life or limb. However, pelvic fractures and femur fractures are an important cause of shock. This is why always check the pelvis and check it once only. Do not do repeated examination for that, as our colleague Dr. Farah mentioned. And always apply a pelvic binder if you are in doubt that there is a fracture, because maybe the patient might be obese or overweighted. Regarding the femurs, simply you will see a malangled limb. So just put it back in position and apply a splint. If you don't have a splint, just wrap it to the next limb next to it. So this is why one of the reasons you have two legs, one is fractured, you can splint it to the other leg. So inshallah, we will explain the significance of MSK trauma and identify life-threatening and limb-threatening injuries and the initial management. So we received a patient who is 19-year-old victim of RTA, who presented unconscious with a pulse of 125, respiratory rate 27, BP 90/40, and hypoxemic with a saturation of 85%. He has a deformed right thigh with amputated left lower limb above the knee with active bleeding. What would you do? Usually in those situations, when people, or especially juniors, when they see people or people who don't manage trauma very frequently, when you see blood coming out and it is spurting, you get shocked by that. Yes, we respect that. You have to stop it, control the bleeding. But remember, this is part of C. So you can ask one of your colleagues to apply pressure on that and apply a tourniquet and go back to the airway, because this patient is unconscious. So the priority now, according to the ATLS guidelines, is going to be the airway, because once you secure the airway, you can manage. Remember, the brain only have 5 minutes to stay alive without oxygen. After that, the recovery or the damage that will happen will surpass the bleeding that you had in your that the patient had in his left lower limb. So always secure the airway, make sure, and then rule out life-threatening injuries in the chest, then examine the abdomen, then go to the C. In the C, there is an abdominal component and the limb component. If there is a fractured femur or pelvis or an amputated limb, apply pressure, apply tourniquet, and carry on. So remember, it is always a teamwork. Trauma is a teamwork. I know some people, they ask about, we don't have a team. Yes, we respect that. That's true, because ATLS was done for the general practitioners who are in rural areas. One doctor, two nurses can take care of a trauma patient. Again, if you are alone, nobody is there, try to gather your team, arrange them, give each one a responsibility, and you manage the airway and breathing and circulation. You can do it. Trust me on that. It is very simple, very easy. It takes 10 to 15 minutes, but trust me, the effect is very, very tremendous, because you will do small, simple things and you will save the life. So always our musculoskeletal trauma is in the C component, where external bleeding and occult blood loss and long bone fractures you discover, and you have to treat them accordingly. Remember, intra-abdominal trauma, you have to give blood. resuscitate the patient. Pelvic fracture with active bleeding, you put a binder. A fractured femur, you put a Thomas splint or just simply wrap it to the other limb. So you control the bleeding. Why should we control the bleeding in the limbs? Directly, we usually teach our medical students and in the junior years that control the bleeding, it's in the primary survey. You have to stop it because you don't want to give blood from his veins in his arm and it's going down to the limb and it is lost there. So you're losing all your resuscitation. Remember what you are resuscitating the brain. You want to supply oxygen to the vital organs, brain, heart, kidneys. The limb, apply simple pressure and apply a tourniquet above the bleeding. You have to see the bleeding stopping while you are applying the tourniquet. Remember, what we see in the picture here, this is a commercial available tourniquet. But if you don't have it, you can apply a simple tourniquet, the one you use for extracting the blood, but it is very soft. Remember, if you apply any type of tourniquet, it has to stop the bleeding and you have to document the time that you applied this tourniquet because we have certain limits. You have to know when you apply it so you can release it and then unrelease it later on. You don't want to put a tourniquet and the patient is covered and later on you end up by ischemia. It might happen, yes, but saving the life with stopping the bleeding is more important about causing ischemia to the limb. Splint the extremity. If it's a closed fracture, just simply splint the femur or the lower limb or the upper limb, because simply it will prevent further injury in the neurovascular bundle, and simply it will preserve the hematoma, which is already there. But always remember that he might have a compartment syndrome, and compartment syndrome in a conscious patient, you can detect it by the complaint of pain and paresthesia. But in an unconscious patient, you have to check it yourself. So you have to know the anatomy, you have to know the compartments and how to examine them. Simply, you will find them tense, and the treatment is very simple. So the rationale of splinting, as mentioned, it prevents further blood loss and injury, can restore, maintain perfusion, relieves pain, important during evaluation, and please do not delay the management of the patient. Don't say, okay, I will do it later on. No. Apply the splint, like in this patient, this is called a Thomas splint, where you, if you can see my mouse, where you wrap it around the thigh and one above the knee and one below the knee and then one below the fracture, so you can apply traction from this area. Don't apply excessive traction, just enough to stabilize it and prevent further injury, and then you have to cover your wound. So in secondary survey comes after the primary survey. Primary survey is A, B, C, D, E. After you expose and protect from hypothermia, which is a major issue in trauma patients. In the secondary survey, when the patient is stable, to be examined from head to toe. You have to examine every inch of the patient, front, back, up, down, right, left, between the thighs, in his scalp, behind his ears, his genitalia, his anus, between the fingers. You have to press on every inch of the patient to see if there is a click or a cracker or an instability. Examine every joint. You don't want to miss a small scaphoid fracture in the patient, and he will be it will affect his work. It will affect his life. He cannot eat. You might miss an injury that will affect the patient's life in the future. So if the patient is awake, job well done. You can ask him about pain, paresthesia, numbness, look for signs of bleeding, hematoma, hard signs and soft signs. Listen for a bruit and feel for a click, especially in the back, in the spine when you do a log roll. So looking for deformity, looking for wounds, apply gauze on that, do thorough irrigation for that. You can use the Doppler, the handheld Doppler for a bruit to check the triphasic or a biphasic or a monophasic. You can ask your vascular colleagues, they can make you listen to that voice, and you can feel a crepitus, skin flaps, neurological deficit, pulses, and tenderness. Remember, if there is a fracture and you apply a splint, you have to always check the pulse distal to the fracture. If he has a fractured femur, please check the dorsalis pedis pulse. Make sure that if it is there after you apply traction, because the aim of applying traction is to restore the blood flow to the lower limb. So if you apply traction and if there is no pulse in the distal limb, reapply it. Make sure it is applied very well with the required amount of tension without excessiveness, and make sure that the pulse is regained after that. If it's not regained, then check for hard signs and soft signs of arterial injury. Is there a pulsatile hematoma? Is there active bleeding, spurting? Is there a bruit over that hematoma? Then you might need a vascular surgeon to come to assess that patient. But remember, those injuries will not surpass the initial ABCDs. And please feel the patient pain and try to look for fractured bone. Patient might be intoxicated. Sorry for the spelling mistakes in the slide. Patient might be intoxicated. He might be unconscious. You might intubate him and give him sedation. So please overthink, feel the pain, think about the mechanism of injury. Patient fell from 2 stories, so he has to have a fracture in his leg. You have to look for that fracture. Do not get fooled by the patient is having no external injury. No, he might have it, but he did not show the response for that. There is no skin changes or bruises, but you might feel a click at the end of the day. So important information to gather from the paramedics and the patient family will be pre-injury status and predisposing factor. Remember, an old guy falling from the stairs, he did not slip on the floor. He might be hypoglycemic and he slipped on the floor. He lost consciousness at the top of the floor. Then you find him at the bottom of the stairs. So he had the first cause to cause this loss of consciousness is going to be either a hypoglycemia, a subdural, an intracranial hemorrhage, an MI. Do not forget that this patient is not a trauma patient. You have to know the mechanism of injury, ejection from the car, a rollover, pedestrian, fall from height, explosion, and so on. So you can then anticipate the injuries. The time of injury, to document it, if you apply a tourniquet, so you can calculate how long you can keep this tourniquet. Unassociated factor, environment, he slipped in the floor, it was ice outside and so windy, there was rain, there was flood. So you have to know that then you will manage a trauma patient with hypothermia or with drowning or near drowning. So you have to consider that and keep it in mind. The pre-hospital observations and care. This is a very important step, asking our colleagues, the paramedics, where did you find him? How did you find him? Did anybody move him? Did you find him in a pool of blood? Did you find a penetrating knife in his chest and somebody removed it? Was there a fight in the scene? Was there a gunshot? So you can see, you can anticipate the injuries. If the patient was involved in a fight or so on, you might find the stabs in the back, but from front you can find simply nothing. So the early management is needed. So you need to call the orthopods for an urgent consultation for open wounds, especially because antibiotics is going to be started. He might need debridement, he might need an external fixator, and also the vascular surgeons for the possibility of a vascular or a neurovascular injury. One of the entities that you should monitor daily, even after you got a patient admitted in your ward or in the ICU with fracture, is the compartment syndrome. Well, if you are working in a fancy place, you can have a device that will measure the intercompartmental pressure. Simply need it. It's a simply machine with a needle that you put it inside the compartment and then you measure it. But not all the hospital has that. It can cost around $2,000 for that machine, but simply you can do it clinically. Remember, do not lose your clinical sense depending on the investigation or the gadgets you have, because one day electricity will be out and you don't have power supply for that machine. So please keep the clinical sense. Palpate the compartments, anticipate by an early paresthesia, a foot drop in the leg, because simply a blade in the operating theater, you open all the compartments and the patient's limb is saved. The vascular compromise is going to be decreased by reducing fractures, splinting fractures, assessing by Doppler, ankle brachial index, which is the systolic in the ankle, and then the brachial systolic blood pressure, and you divide them, and then you have the ankle brachial index around 1 above or 1 or below, which will give you a suspicion of acute, chronic, or critical limb ischemia. If you are having a patient you are really stuck with, call the surgeons, call the orthopods, call the vasculars. Always ask for help, no matter how senior you are or how junior you are. This is the first rule in medical school, is please obtain help when you need it. And trust me, people will come running for helping you. The open fractures, the problem with that is that you will lose tissue. It might be a degloved injury. You might have a neurovascular compromise. You might have tissue loss. So those patients with open fracture who are stable and you're doing your primary or the secondary survey, please irrigate them well with normal saline. Simply apply gauze in that and wrap it and just make an incision or keep your dressing open over the pulse, palpable pulses, so you can just frequently palpate the pulse. If you apply a back slap or a splint or a POP, just please make a small hole over the dorsalis pedis, the posterior tibial, and so on, just to check the pulse frequently. No need to unwrap the patient again. Consider time factor and antibiotic and tetanus status. Please don't forget the antibiotics and tetanus status for open dirty wounds. And remember, the dilution is the solution for pollution. Just irrigate it thoroughly. Do not remove any tissue. Do not finger the wound. Just irrigate will decrease the bacterial load. Obtaining an X-ray in trauma patients. Previously, they used to say a cervical, chest, and pelvis. Cervical now is replaced by CT scan, or just apply a cervical collar until you rule it out in a conscious patient. Unconscious, he has to have it until he wakes up. CT scans, you cannot do it for the lower limb. Rarely we do that for special indications, but we can do a simple X-ray to see what type of fracture, simple comminuted butterfly. So you have to X-ray the bone or the limb that you are suspecting that there is a fracture on one joint above and below. When do I obtain them? When he is hemodynamically normal. That means if he has a fracture humerus, you can apply a splint, or a fracture radius. Just apply the splint in the anatomical position. You can get the help of the orthopods for that. And later on, you can do a further X-ray, because the patient's priorities is always a priority. Airway breathing. If he's going to surgery, then just apply the cast or apply the splint and take him to surgery. During the surgery, remember that you have to check the pulse and document that you have a fracture here, needs further investigation. When should I delay getting an X-ray? If there is a life-threatening injury, take priority. If patient transfer will be delayed. So, in compartment syndrome, which is one of the missed things that might develop after, maybe initially after the injury or a couple of days after the injury. So how can we know that? We have to anticipate. Remember that the eyes doesn't see what the mind doesn't know. So you have to anticipate with looking, listening, and feeling. You can ask for a further investigation. But if you suspect that there is a compartment syndrome, you can proceed for fasciotomy. Usually it is more common in the lower limb in closed fractures, but it happens in the upper limb and in vascular bony injuries. And don't please apply a tight dressing. Stopping the bleeding is not by wrapping too much crepe bandage around the injury. It's not a tourniquet. No, stopping the bleeding is by direct pressure. So if you have a bleeding point in the forearm, in the antecubital fossa, just apply 10 pieces of gauze and just simply wrap around it a gauze. I prefer cotton because gauze can cause skin necrosis if it is unnoticed. You can apply a cotton bandage. If you apply a back slap, please do not make it tight. It's only to hold the bones in place. It's not to fix it like a nail. In crush injuries, which is more common in motorcycle injuries, anticipate that. And in burns, You see, it's only a simple line with a blade. You open the skin, you find the fascia, you open the fascia, you save the patient's limb. Later on, the plastic surgeons can help us in covering that. But I saved his limb, and I saved his motor function, and I saved his life. So how do I recognize compartment syndrome? Simply in a patient who is having good level of consciousness by pain, disproportionate diameter or circumference, or in passive stretch. When you stretch the muscles in that compartment by dorsiflexion or plantar flexion, you will have pain. Tense compartment, but in overweight patients, that's going to be a little bit difficult. Asymmetry in the limbs, and paresthesia, which is the earliest sign of that, and tissue pressure more than 35 to 45 millimeter mercury. So in summary, musculoskeletal injuries may cause delayed threats to life and limb. You have to stop the bleeding by applying direct pressure or tourniquet, or you might do it by surgery if it's in the neck, reduce the immobilized fractures and dislocations, recognize vascular compromise, and consider compartment syndrome. Any questions? And thank you.
Thank you, Dr. Mohammed. Thank you, Dr. Mohammed. And
welcome.
يعطيك العافية. So we will open the floor for any question, and I can see here already the question zone. This is, I think, related to the previous presentation.
Yes, actually, it was not present, and just they have written these questions.
Okay.
Please, Dr. Bara.
Dr. Bara is around?
Yes, I'm here.
Yes.
So, what do we have questions? When is the best time to use FAST in primary survey or the secondary? No, the FAST is adjunct to primary survey. So that means just after the primary survey, or can be used even within the primary survey if we spend time in C, in resuscitation and control of bleeding, we can use FAST. And the benefit of FAST also, it's repeatable. We can use it in primary survey, after primary survey, during secondary survey, and later on it's repeatable ultrasound. Any further questions?
Just looking.
Yes, Dr. Bara, and one question saying if you open the abdomen and you find there is a retroperitoneal hematoma, what is the best way to do?
If you open the abdomen and find retroperitoneal hematoma, it's some complex and need intraoperative judgment. Zone 2, that means lateral extraperitoneal hematoma, if you find it, you can observe it unless it's expanding or pulsatile hematoma. You can call your colleague in vascular, or if you are expert surgeon in vascular surgery, you can open it, or if you are a trained trauma surgeon. Zone 1 hematoma most likely need to be explored by also even trauma surgeon or vascular surgeon or expert general surgeon in trauma. For Dr. Mirza, if you have comment, you are a senior and expert in trauma.
Yeah, thank you.
I can see some raised hand. We'll start with Dr. Amado. Dr. Amado, you can unmute your mic and you can ask your question, please.
Hello, good morning.
Good morning.
Okay, I have one question. If you have a number 3 travel, when you have travel, you be accidents. You meet up, one patient have a fracture about femoral fracture.
Yes.
Yeah, when we have meet up this kind of patients, but the emergency hospital is more than 1 to 2, more than 7 hours. What you can do?
Okay. So, Dr. Mohammed Wudenli.
Yes, thank you for the question. Remember, in trauma, when trauma was done by, I think, an orthopedic surgeon who had a plane crash, him and his family. So he was flying somewhere and they crashed, and nobody, when they took his children and family to the hospital, they didn't know how to do. This is how ATLS was invented long time ago. So it happens, yes, when you have traumas long away distance from the hospital. The priorities are the same. Make sure that he has a good airway and manage the breathing and the circulation. When it comes to a femur fracture, maybe you are in the middle of the desert, like here in Saudi Arabia, or you might be middle of the jungle. So simply put the patient supine, make the priorities, rule out life-threatening conditions. When it comes to the fracture, just simply apply traction and wrap it with the other limb. Apply a tape or a bandage around both limbs so you are splinting it to the other limb. You are using the other limb as a splint. Nothing more than that can be done. You cannot offer. Remember, you have to have resources to treat patients. So sometimes resources in some injuries are very limited, and it does a big difference in the patient life. Immobilize it, prevent further injury. If something happens, there is nothing to do. This is his fate. But simply, you can just only splint it to the other leg.
Okay, Dr. Mandir Basinda, you can unmute your mic and you can ask your question, please.
Hello, assalamu alaikum.
Alaikum assalam.
Okay. My question is about compartment syndrome. If someone is unconscious, how can you check for the compartment syndrome? Yeah.
Okay. Thank you.
Yes, that's one of the dilemmas that you will face in unconscious patients. They will not tell you that I have pain. So number one, anticipate. If there is a fracture in both bones in the right lower limb, as an example. So number one, we have a suspicion that compartment syndrome might be there unnoticed. Number two, you can feel the distal pulses, though it is the last sign to appear in compartment syndrome, and you will not find it, or we don't want to reach to that level. Number three, you might find some foot drop if it's in the lower limb. You can simply see the foot drop if the patient is supine. One of the things that you can do, that if you do passive flexion of dorsiflexion of the leg, the patient will feel pain, so you can see the pulse rising on the monitor. That is one of the signs knowing that this patient is feeling pain. Okay, he is unconscious, he's having both limb fractures. I can feel the pulse. If I compare it to the other side, it might be weak. This is one of the things that you can look for, comparing to the other limb. You can use the intercompartmental pressure if you have that machine. Okay, if I have none of those, what should I do? So I suspect no pulse is there, little bit weaker, or I cannot determine, there is no measurement, patient is unconscious. I can feel the compartments. It is usually in the anterior lateral compartment. The posterior ones, yes, you can feel in the deep part. But the anterolateral ones, the two compartments, and the lateral one, you can feel hardness. So just compare it to the other side. You will feel more tense. Okay, I cannot determine if it's truly there or not. I recommend you can proceed if you have a high index of suspicion that this patient might have a compartment. You can ask your fellow vascular or the orthopedics. They can help you with that. If you are having high index of suspicion of a fasciotomy, you can do it. It will not harm the patient. You can do a diagnostic incision on the same site. If you open the skin, you open the fascia, and you start seeing the muscle bulging out, continue your fasciotomy. Otherwise, if the muscles are okay, the pressure in the compartment is okay, you can stop the procedure there, apply the dressing. Don't close it, so you can check it later on. Okay?
Okay. دكتور محمد الزاري. تفضل دكتور محمد. Dr. Muhammad, you can unmute your mic and you can ask your question, please.
You can hear me? Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullah.
I am Muhammad Ali Al-Azri. I'm resident emergency medicine from Alexandria University, Egypt. Currently, I'm in Zanzibar, Tanzania. I would like to comment a little bit on compartment syndrome, where I've attended a patient who the upper limb, the left hand was full gangrenous, black colored after applied a cast about 4 days ago when the child fell down from a tree. So the patient was complaining of pain. When the patient returned to the doctor who applied the cast, he was told that it's okay, just return back home. When the patient came to hospital, the upper limb was fully swollen with blackish, greenish, grayish color, no sense, no motor function, and amputation was done. So I would urge my fellow colleagues that before applying a cast to a patient who has been having a trauma, make sure that the compartment syndrome is ruled out to avoid unnecessary amputation to poor kids. Thank you so much.
Thank you for sharing this information. Dr. Mujtaba Ahmed.
Yes, hello and good morning. My question is, it is known that it is contraindicated in pelvic injuries where we suspect a bladder injury that we should not catheterize the patient. So my question is, what should we do in this scenario? Thank you.
In patient with pelvic injury, and you suspect there is a bladder injury. So what to do for regards catheter or fully catheter insertion? Is that correct? If I rephrase your question correctly. طيب, Dr. Bara.
That is correct. Thank you.
Dr. Mirza, if you can answer him.
Yes, please. Regarding the suspicion of urethral injury, of course, there are signs for that, like blood in the meatus, presence of fractured pelvis, hematoma in the scrotum. So in such cases, as you said, Foley's catheter is contraindicated. So what we need to do, we need to, if available, we may do ascending ureterogram and see whether it is really injured or not. If not available and we don't know how to do and it is highly suspicious, and we need to drain the urinary bladder, we go direct for suprapubic catheter insertion. Fine. And if you have a urologist beside, you can consult him and take his opinion. So urethral ascending ureterogram to clear the diagnosis, and then suprapubic catheter insertion. Okay.
Okay. So thank you so much, Dr. Mirza. I think we will proceed with our next presentation. My next presentation, it will be about the thermal injury. So Bismillah ar-Rahman ar-Rahim. It's my pleasure to be among my colleague in IMSA and give me this opportunity to participate. I am Dr. Isam Bataya, pediatric and advanced MIS consultant, head of general surgery department in Al-Noor Specialist Hospital. I will speak with you today about the thermal injury. So our objective is to have the basic principle of the initial trauma resuscitation and the timely application of the simple emergency measures, estimate the burn size and the presence of any associated injury, demonstrate and measure of initial stabilization and treatment of patient with burn, identify special problem and method of treatment with burn and with cold, and the specific criteria for transferring such patient. So in classification, we have 4 type major thermal injury. Is it burn? Is it electrical burn? Is it cold injury? Or is it a chemical burn? So what is the first thing to do? As my colleague initially highlighted and speak in every presentation, it is the A, B, C, D, E. So you have to have the airway protection with C-spine, breathing and circulation, and regard the disability and the exposure for the patient. So initially with the airway, the immediate life-saving measures that you should look for in such patient, how to identify a patient with an inhalation injury, as the most dangerous issue is if the patient has this inhalation injury, you should discover it and as early as possible, because later on when the patient starts to deteriorate, it will be a little bit difficult to intubate the patient and resuscitate him. So how to identify that? By looking for any facial burn, for any thinning of the eyebrows and the nasal vibrissae, and if there is any carbon deposit in the oropharynx, or if there is any carbonaceous sputum. So such patient, you anticipate that he has an acute inhalation injury. So the treatment is, it should have and secure his airway as early as possible by doing intubation, and to obtain for him later on chest X-ray and looking for any other measures. Immediate life-saving measures, especially for the patient with carbon monoxide poisoning. We know sometimes if the people getting cold, they start to making fire. And if they did that, there is too much of this carbon monoxide. If they start to be in an enclosed room, enclosed area, can lead to carbon monoxide poison. So people usually, they will have initially headache and nausea, and this is occurring about 30% of the patient. Then they go and getting worse with the confusion. Then it's getting worse with the coma, and unfortunately, it might end up with death. So as an advice, please always, when there is an area with the charcoal or making a fireplace, it has to be well ventilated and there is a good circulation of the air in there. And the main reason that we know that the carbon monoxide has higher affinity to the hemoglobin, 240 times. So that's why those patients will have this kind of poison. Then the continue of our life-saving measures is to stop the burning process. So initially you have to remove all the clothes on the patient and to take everything off. And try, if there is some area that's too much adherent to the body, those you can keep it and just keep it there. Then you have to start intravenous line. As mentioned earlier with our colleague, that the best thing is to do 2 antecubital fossa and to give IV fluid. And especially if the patient burn surface is more than 15 to 20% of his body surface. And even if this is overlying the burned skin, should not deter the placement of the line. If you can see it clearly and securely that you can put the line, you can do it there. And start isotonic corticosteroid. How to assess the burn patient? Starting as usual with the history, the mechanism, associated injury, and there is any pre-existing illness, and as mentioned earlier by my colleague, regard the ample history. Next, the body surface area. There will be a rule of 9, and there is a small difference between the estimation between adult and infant and pediatric age group. And the third and the last thing is the depth of the burn. There is first degree, second degree, and full thickness. So starting with the body surface area, as you can see here, we have the rule of 9. This rule of 9, that's mean we have the 9% of the trunk, the torso, and the 9% of the anterior surface, 9% of the anterior surface of the lower limb, and 4.5 for the anterior surface of the upper limb. So all the both lower limb, anterior and posterior, is 9. So, and the head incomplete anterior and posterior as 9. But in the pediatric age group that we can see there is little bit of difference. The torso and the chest of the pediatric age group, it's around 18%, and the back is 13%. The head anteriorly 9% and posterior 9%. The lower limb anteriorly 7%, posteriorly 7%. There is another type of measurement that you can apply is it's called the area of the palm. It's the 1% body surface area. So any area of the palm here, it's can concluded as 1%. That's an adult. So the first degree patient will arrive and he will have erythema, pain, and no blisters, and it is no life-threatening condition. And this patient can be treated safely and discharged home. Then patient with partial thickness burn, it will have a redness, it will have a mottled appearance, there is a swelling, there is some blistering, it is very painful, and it is hypersensitive. And finally, the full thickness burn. And those, sometimes you will see it dark or leathery, and it will be like this whitish. It's translucent, white, waxy, and it is painless. And this is the most important characteristic. So if you put your hands on them and he cannot feel anything and painless and doesn't flinch, that means it is a full thickness burn. Usually in practice, it's common that you can see a different combination between multiple areas with multiple thickness injury. So some area, as you can see here in this picture, some area it is a full thickness, the other is deep partial, and some other which is very superficial. So you can see all the 3 degrees in one patient. Circumferential extremity, and especially regard special consideration for the chest and the abdomen. This is a very important issue that you have to remove all jewelry and everything and to rule out the compartment syndrome, just as earlier described by my colleague, Dr. Muhammad, and assess for any distal circulation and shaking for if there is any cyanosis, if there is any impaired capillary filling, and if there is any progression of neurological sign, which mainly the pain. And if you have the facility and you can do the Doppler ultrasound, you can just do it. And the best treatment is to do ischorotomy, and this is just needed within the first 6 hours of the burn injury so that to relieve and can allow the tissue to be vascularized. So circulation and the burn shock resuscitation, there is a special formula, and this special formula in a way that how you should resuscitate the patient with the amount of the IV fluid. It's a well-known as Barkland formula. It is the initial fluid rate will be 2 to 4 milliliter of ringer lactate per kilogram of body weight per percentage of, but you will count only the 2nd and the 3rd degree burn. So the 1st degree, we don't calculate it in our equation. Half of this amount should be administered to the patient in the first 8 hours after the injury. Take in consideration that maybe this patient already arrived to the hospital 1 hour or 2 hours after the injury. So you have to make sure about that and to calculate the amount that you should give it. Then the remaining that you can divide it over the 16 hours to be given. The adjustment, it could be according to the urine output. As mentioned earlier in the lecture of the shock, the most indicator that you are resuscitating your patient well and you give him a good resuscitation or not, it's depend on the urine output. So you are looking for 0.5 ml per kg per hour in adults and 1 ml per kg per hour in children. Pediatric burn resuscitation. A prompt resuscitation is critical in pediatric patient due to their small circulation of the blood volume. Any delay in this resuscitation, it can increase the complication and increase the mortality. Ringer lactate solution should be started in patients of all age. And due to the limited their glycogen store, the infant is at risk of hypoglycemia if the glucose source is not provided. So sometimes you have to add to it some glucose. Their blood glucose level should be monitored very closely, and the source of 5-dextrose, as I mentioned, you can provide. Then the secondary survey that related to the adjuncts, the baseline and the X-rays as needed, insertion of NGT and gastric tube, giving any narcotics and analgesia, as mentioned by Dr. Mirza earlier. Pain management is very important. Give small doses of IV, wound care, and antibiotic. Then we'll move on to chemical burn. We know that we have a lot of household detergents, and most of it is dangerous. And unfortunately, the most target people is by accidentally is the pediatric age group. Most of those are strong acid or alkali or petroleum product. They destroy the texture and of the tissue, and this chemical burn is influenced by the duration of the contact, the concentration, and the amount. The best way for the management of this chemical burn is by flushing with a copious amount of water for 20 to 30 minutes. Electrical burn, more serious than it's appear. It's usually looking in the surface nice and clean, but underneath this surface of the skin, you will see a disaster. Rhabdomyolysis, it's a result in the myoglobin that released and can cause acute renal shutdown. Patient should be monitored with ECG monitor, and please try to put Foley catheter, check for the urine color, and looking for the diagnosis and early diagnosis of myoglobin urea. Patient, usually if you have the capability and to do for them ABG, they can show metabolic acidosis. That should be corrected as early as possible. Cold injury, frost nip as the most common, and lucky enough that we are in the Middle East, North Africa, and our Mediterranean country, we don't see much of that cold injury, but we will just go through it for your knowledge. It's the mildest form, and usually it's like this white color on the tip of her nose, and it is usually come with severe pain, pallor, and some numbness, and it is reversible with just rewarming. Regular rewarming, it can do the job. Then the frostbite, then this is with different 3 degree. The freezing of the tissue from the intracellular, it's forming an ice crystal formation, and this can lead to microvascular occlusion with subsequent tissue anoxia, and it can be very dangerous, and it might reach to a degree that it can be irreversible. Non-freezing injury, this is prolonged exposure of the extremity to the cold sea or the water, and this is most commonly in sailors and fishermen. The usually above the temperature of the water, it's usually above the freezing, and it is due to chronic exposure. How to do the proper management of such cold injury? Place the injured part in circulating water at 40 degrees until it became pink color. Avoid the dry heat. Again, please avoid dry heat. Do not rub or massage the area. The rewarming process is usually extremely painful, so please give your patient a good analgesia. Adequate analgesia is mandatory. cardiac monitoring is advised. In conclusion, the early recognition, please, of any inhalation injury is a priority. Fluid resuscitation and to give it according to the formula that we just mentioned. Just know the rule of 9 and estimation of the burn surface area with the degree, and do not ignore the associated injury that must be ruled out. Thank you, and we open the floor for any question. There is a question, why half of the amount of the total fluid volume resuscitation should be administered within the first 8 hours, and why do we use a ringer lactate? Regard the timing, I think it's according to the studies that the volume that the patient is losing. So you have to resuscitate this volume as soon as possible, and you give him at least half of this volume within this time frame for this 8 hours. The type of the fluid and the ringer lactate, it's just only as a recommendation according to the component that the availability of the electrolytes and the balance and the isoosmolar of the solution. What is the role of TBN in burn patient? Actually, this is a long run thing. Patient with TBN, this is the patient who has inhalation injury, but it is not the first line and it is not the rule. If you can feed the patient enteral feeding with nasojejunal tube, nasogastric tube, nasojejunal tube, it would be the best route, and preferably, if not such patient, yes, you can start with TBN. What about antibiotic? Yes, Dr. Bukhari, yes. We should give the patient antibiotic, and always we are covering the patient with antibiotics. Dr. Hassan Yamur, he has a question. We'll give you the mic. You can unmute your mic to talk, Dr. Hassan.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullah.
Good morning or good afternoon, everyone.
Good afternoon.
In the rule of 9, there may be under or overestimation of the for the resuscitation of the burn patients. I mean, the under or overestimation of the burn size. So, how can we control the over and under resuscitation, especially in rural areas where there is no renal function tests or even a CVC machine to see the electrolytes or the renal status, that we cannot do that in rural areas.
Okay, I get your question. First of all, the under and the estimation, it is a roughly estimation. That means something is not that 100% accurate. So my estimation, it can be different from your estimation, but at least we know that the rule of 9, it works. That means if the burn injury, it is mainly on the upper limb. So that means this is 4.5 anteriorly the surface, and maximum that the range will be for this from 4.5 to 9%. Yes, I will not give more than 9% for an upper limb. So at least this rule of 9, it's make the margin of this error is closer and it's not that extreme. This is 1. 2, you don't need any lab work to see if your resuscitation is good or not. The most important is the patient urine output. If the patient start giving a good urine output, that means he's doing well and everything is fine. If it is not, that means yes, he is not doing well, and you need to go more with that. دكتور أمادو. دكتور مرزا أنت كنت بتضيف شيء. Would you like to add anything أو you have any comments قبل شوية؟
No, it's fine, it's fine. Thank you.
طيب.
Hello, assalamu alaikum.
عليكم السلام دكتور بسندة.
My question is, you know, like not all burn in pediatric is accident. Some of them is like child abuse, right?
Yes.
Yeah, so I just want you to share your experience or any other doctors. How did you, like, did you ever have this kind of case and how did you solve this kind of situation?
Okay.
Yeah,
Thank you.
you.
Regarding the child abuse, you have to look for any marking and to make sure if it is really an accident or not. According to the authority, according to your hospital policy, how you should deal with such problems. If you have a committee and you have people who is dealing with this, they should be consulted, and the authority in the hospital or the authority in the country, if they have a legal body regard such kind of things, because those with especially child abuse, because the most important and what we are talking here, the management plan. But later on, regard authority and how to deal with it and these things, it's different from country to country, from hospital to another. What you have to do first, if someone burn at home before you go to the hospital, if it is as usual, the burn that's from hot liquid things, just to take it away and just to apply to it a warm or tap water that's regular water on it, and just put on it a towel or something that's soaked with some water and take him to the hospital. You don't have to do any further thing, unless if it is something chemical or thing. If it is a powder, you can just brush it from the area. And again, you can apply the copious amount of water at home before you take him to the hospital. If there is any rule for the dressing, the light dressing before taking the patient to the hospital, yes. After that, yes. Usually we are covering the burn patient with the special type of dressing according to the facility and availability of this type and material that we are covering such wound with. Right. Since we have no further questions, and I asked the chemical burn prevention measures, especially by the oral route. The most important prevention is try to make that the can it is securely and not reachable for the kids, and avoid splitting the detergent material in a normal bottled water or somewhere that it could be reachable, so that you can do that. Rewarming of cold injury is such painful. Yes, it is very painful. Some people, they advise to pour honey on the burn area. Yes, the honey, it can be a good material or a solution that it could be applied, but we know that from medical and science point of view, we should apply the honey to a good granulating tissue. We have been using it and we are using it in especially diabetic septic food. So it can be used for the burn cases, but not as the first line of management. Right. We can move to our last presentation, and in our program, it's my pleasure to introduce our colleague, Dr. Ahmed Kamal. Dear Dr. Ahmed, you can start sharing your presentation, please.
Thank you, Dr. Batayan. It's my pleasure to be here with you. That I would like to introduce myself. I am Ahmed Kamal. I am a consultant vascular surgery in Security Forces Hospital, Mecca. I am professor of vascular surgery in Ain Shams University in Cairo. I will open my presentation 1 second.
After you open the presentation, you just press the share button so that, and you select that presentation you just opened, the PowerPoint.
I will open the share.
في زرار تحت مكتوب عليه share screen.
Yes.
لما تضغط عليه كلمة share screen يطلع لك كده لوحة. اختار اللي هو الباوربوينت البرزنتيشن اللي انت حضرتك قبل شوي فتحته.
حاضر لحظة.
انت شايفه اللي هو الازرار اللي هو حق شير سكرين؟
لا مش شايفه الحقيقة. لا مش شايفه. أنا كنت شايفه من شوية لكن اختفى، مش عارف راح فين الحقيقة.
تروح شايف الماوس، تروح بالماوس فوق اللي هو على السنتر اوف ذا بيج، الابر كورنر كده فوق، تمرر الماوس هناك تنزل لك السكرين.
لحظة. في
في ازرار كده مكتوب عليه شير ذا سكرين.
ايوه انا كنت شايفه. لحظة واحدة بس. في شير والشير
انت على السبيكر فيو ولا على اللي هو فول سكرين فيو؟
لا على السبيكر فيو.
اوكي. لما انت على
السبيكر
على السبيكر فيو تحت في الاسفل الشاشة.
ايوه خلاص.
شير سكرين.
مظبوط. I have it now. share the screen. share الكمبيوتر. اوكي.
ممتاز. يس. الان ممكن حضرتك تكون تحطه على فول سكرين.
شايفني حضرتك دلوقتي كده؟
ايوه شايفك، بس ممكن تعمله فول سكرين. ايوه.
يس.
ممتاز. يس يو كان جو.
السلام عليكم ورحمة الله وبركاته. It's my pleasure to be with you here in this webinar, and thanks for the faculty to invite me to give these 2 lectures regarding the head trauma and the spinal cord trauma. In the objectives, we will start by introduction in the anatomy and assessment of ABCDs and head injuries and head trauma management, then the summary, and we will shift to the spinal cord injury. The traumatic brain injury, which is a TBI, is #1 cause of traumatic death worldwide. There is bimodal distribution in the ages from 0 to 4 and from the 15 to 19 years. It accounts for 71 all pediatric trauma hospitalizations, which is very high incidence, as you see. There are falls in the etiology. Falls is the most common thing, followed by motor vehicle accident and pedestrian impact. Then the assault is the least. It's mild to moderate or severe, focal or diffuse, blunt or penetrated, open versus closed, depressed or non-depressed. The basic injury is primary or secondary. The primary injury from forces impacted at the time of the accident immediately, then secondary occurs after the initial impact, which is very important to detect and to prevent, including hypoxemia, ischemia, initial hyperemia, cerebral edema, and expansion of the hemorrhage or the hematoma. The pathophysiology is as we said, the primary injury and then the secondary injuries. As a reminder of the anatomy, the layers of the scalp and the head, skin, then periosteum, then cranium, then dura, and the arachnoid matter, then the pia mater, and there is the brain tissue. There is what is called the Monroe-Kelly doctrine, which is the hypothesis. It's a balance between the size of the venous and arterial volumes, then the brain tissue and the CSF. When there is hematoma or mass effect here, the mass effect, it will produce what is called autoregulation. Autoregulation starts to maintain the brain size constant, no pressure on the brain, by losing the CSF or decreasing the size of the CSF or the venous volume decrease. Then when the mass increases, the autoregulation will decompensate it. So it will produce mass effect on the brain and the brain tissue, which is called herniation. This is the graph between the relation between the intracranial pressure and the intracranial volume. The intracranial pressure is very important to be maintained by preventing the hypotension and hypoxemia. The autoregulation, meaning that the autoregulation mechanism will maintain the cerebral perfusion pressure, which is the equation between the mean arterial pressure minus the intracranial pressure. The normal one is from 70 to 100 millimeter of mercury. Then, how to manage the traumatic brain injury or head trauma? We will start with the ATLS protocol, which the ABCDE. Then we have to focus on the D, which is the disability. 3 components: the glaucoma score, pupillary exam, which is the size and reaction to the light and equality on the both of them, and the rising signs. Then we have to resuscitate the patient with the standard techniques and don't postpone treating the hypotension. Then prefer the crystalloid as the hypertonic saline or isotonic saline according to the situation and the blood components. Assessment of ABCDE, secondary survey, assess for other injuries, the complete neurological examination and radiological evaluation in hemodynamically stable patients, CT of the head, which is the gold standard. This is the glaucoma score, 3 components: the eye, verbal, and motor. Eye, 4 components, verbal, 5 components, and motor is 6 components. there is some things to make us to remember these. It's the eyes. We have 4 eyes, the 2 eyes and the glasses, and verbal 5 words, and motor. It's like the motor of the car. Which is 6-cylinder. Okay, just to remember, eye 4, verbal 5 words, 6-cylinder of a motor of a car. In the pediatric, is the same. It differs a little bit. It's not our scope now. Head injuries. There are multiple mechanisms and multiple pathologies, like the subdural hematoma, which it is located between the arachnoid and the dura, This is stretching or tearing of the cortical bridging veins. It's a venous bleeding. The subdural hematoma, it's a venous bleeding. It takes the shape of a crescent or concave shaped. Mortality is higher than the similar extradural hematoma. Why? Because it's a greater force and slower onset. A rapid surgical evacuation recommended, especially if there is more than ½ centimeter shift of midline, 5 millimeter. So it's a venous bleeding, and intervention should be done if there is more than 5 millimeter shift of the midline. This is the shape of the subdural hematoma. It's a crescent shape. The epidural hematoma or extradural hematoma, it's arterial. If you remember, the subdural hematoma is venous bleeding. The classical presentation, this is brief loss of consciousness. There is lucid interval. The patient in between the primary loss of consciousness and the second loss of consciousness is mostly completely normal neurologically. Then obtundation, then contralateral hemiparesis or ipsilateral pupil dilatation. It is here convex shaped, and early evacuation is essential. This is the shape of the epidural hematoma or extradural hematoma. It's a lenticular shape or convex. Then cerebral contusion, the injury of superficial gray matter. It's the classic pathology is coup or counter coup lesions. The location in the temporal lobe mostly violates the blood-brain barrier, may enlarge in the first 12 hours. Edema may worsen after first several days. This is the mechanism, and this is the shape or the picture of the cerebral contusion. Intraparenchymal hemorrhage, similar to cerebral contusion, but it increases over time and more produce increasing mass effect or neurological deterioration. This is inside the brain matter, which is going to be deeper. Then subarachnoid hemorrhage or SAH. This is between the bia and the arachnoid. If you remember the layers, it is between the bia and the arachnoid membranes. This is also venous tears in the subarachnoid space. It will occur in the vasospasm, then may last up to 3 weeks. Then there is diffuse axonal injury or DAI. There are traumatic axonal stretch injuries or the axonal structural failure due to mechanical forces along the axons. The severity of axonal disruptions is directly proportionate to the amount of the deficit. So the number of axonal disruptions directly proportionate to the amount of deficit. Okay, this is the picture of diffuse axonal injury. There is mild brain injury. The brain injury will be classified into mild, moderate, and severe injuries according to the clinical picture and the Glasgow score. The mild, the Glasgow score between 13 to 15. A history excludes systemic injuries, and the neurological exam, radiographic investigation as indicated. Then the management here is observe or discharge based on the findings. Then the moderate. The Glasgow score here is 9 to 12. Initial evaluation same as for mild injury, but here CT scan should be done for all. Admit that this patient should not go home. Admit and observe frequent neurological exams while he is inpatient. Repeat the CT scan once needed. Deterioration managed as severe hand injury, which is this category. The Glasgow score between 3 and 8 and less than 8. Evaluate and resuscitate. It should be intubated because these patients cannot protect their patent airway. Neurological exam prior to intubation is a must. Then focused neurological exam should be frequent, and also frequent re-evaluation and identify associated injuries like abdominal pelvic trauma, musculoskeletal trauma, chest trauma, like that. Then what are the indications of CT scan in head injuries? Glasgow score is still less than 15 2 hours after the injury. If there is neurological deficit, open skull fracture, if there is basal skull fracture, like battle sign or raccoon eye or whatsoever, vomiting more than 2 episodes, if there are extremes of age, pediatric or geriatric, retrograde amnesia, or there is a severe headache. The management is ABCDE, as we said. Minimize the secondary injury by preventing both hypoxemia and hypotension, and administer oxygen. Maintain adequate ventilation. The goal of partial pressure of carbon dioxide at 35 millimeters of mercury. Maintain the blood pressure. Then head of bed should be from 30 to 45 degrees. Avoid hypotension and hypoxemia. Mannitol, it has a rule in cases of tentorial herniation and should be avoided in patients with hypovolemia. The dose is 1 gram per kg IV bolus. It can be added by also by hypertonic saline. Anticonvulsants can be added to the treatment, sedation, and paralytics. Emergency surgical intervention when to be indicated in head trauma in cases of scalp wound, because it is a possible site of major blood loss. It's the scalp is a very vascular structure. Direct pressure to control the bleeding, occasional temporary closure. If there are penetrating injuries, may need simple debridement with assistance with prophylactic antibiotics. Then intracranial mass lesion can be life-threatening if expanding rapidly. Immediate neurosurgical consultation is a must, hyperventilation and medical therapy. Then last thing, it can be added as damage control craniotomy by a neurosurgeon if there is a possibility to transfer there. What is the meaning of brain death? Brain death when the Glasgow score is 3, non-reactive pupil with absent brainstem reflexes like the oculocephalic, corneal, and doll's eye, and no gag reflex. No spontaneous ventilatory effort on formal apnea testing. In summary, for the head trauma, we have to follow the ATLS protocol, the ABCDE, prevent and minimize secondary brain injury, avoid hypoxemia and hypotension, and early neurosurgery consultation is a must. Thank you.
شكرا دكتور أحمد.
Now I will shift. Yes, any question for this, or we will give the 2 lectures and we will receive the questions for both.
طيب نشوف اللي هو حق الكويستشن انسرز. فيه هنا عندنا هذا كان السؤال الظاهر سابق حق الشايلد كيميكال اكوستيك، والثاني أيوة في هذا السؤال. For example, a woman with 54 years present to the emergency department after motor vehicle crash with head injury. The patient had loss of consciousness on arrival, oriented بعدين 3 times, but asking repetitively question about what happened, and her only complaint is headache. She has a laceration on the right peripheral skull with no other injury. Her GCS is 15 and neurologically intact. Can we scan the patient, or she is not indicated for head CT scan?
This patient may be in the lucid interval. Despite that the glaucoma score is 15, but there is from the history, as the asking student is mentioning in the scenario, there is a retrograde amnesia. So there is retrograde amnesia, there is severe headache. So this patient should be scanned because the clinical examination dictates the necessity of the CT scan as in the scenario.
يعطيك العافية. The other question, I think it is not related. It is about how we can get the presentation video. All of these presentation, you can go through the YouTube channel of the IMSA. We have the live transmission there, and you can access it at any time. Subscribe to our channel, and you can see this video at any time and repeatedly and each lecture. So we will have it downloaded, completed, all this presentation with your questions. It will be there. Any further question, you can raise your hand, please. As far we don't have, so Doctor, you can proceed to your next.
Okay. Can you see the presentation now?
Yes, full screen. Yes, now it's clear.
Yes. Again, we will shift to this next topic in our lecture, which is the spine and spinal cord injuries. The objectives of this lecture, by the end of this lecture, we have to be aware about the goal of the spine trauma care and pre-hospital management. Pre-hospital management is very important. It's very, very important. What are the steps for clinical and the neurological assessment? What are the types of acute spinal cord injuries? And what are the common cervical and thoracolumbar spine fracture and dislocation? The goal of spine trauma care is to protect further injury during evaluation, management, and transportation. At the scene of the accident, maybe the spines or the spinal cord has not been injured, but with mal-management and mal-transportation, you will do the injury during this time. So be careful. Identify spine injury or document absence of a spine injury. Optimize conditions for maximal neurological recovery. Maintain or restore spine alignment. This is the standard of care. Minimize loss of a spinal mobility. Obtain healed and stable spine, then facilitate the rehabilitation. When to suspect the spine cord injury? With high-speed crash, the patient is unconscious, multiple injuries, neurological deficit with spine pain or tenderness in the back. Always in the pre-hospital management, always protect the spine during the management of patients with multiple injuries. Up to 15% of spinal injuries, you have to remember this, have a second or possible non-adjacent fracture elsewhere in the spine. Ideally, whole spine should be immobilized in a neutral position on a firm surface. if you have to transfer the patient or to examine the back with the log rolling, protection is a priority and the detection is secondary. The team leader holds the head, and the assistant 1 and the assistant 2 are holding the spine and the legs to log roll the patient. Okay. Cervical spine immobilization, transportation of spine cord injured patients in the pre-hospital management is very important. We have to, for the spinal, cervical spine immobilization with the safe assumptions, head injury and unconscious, multiple trauma in the fall patient, severely injured worker, unstable spinal column. We have to supply hard backboard, rigid cervical collar, and lateral support with the sandbags. This is the Philadelphia. This is a photo for the Philadelphia hard collar to protect the C-spine, cervical spine. And this is the long backboard, and there are the side immobilization with the sandbags and the long spine board, which is the hard surfaced. Assessment, as usual, A, B, C, D, E, then followed by primary and secondary surveys. Adequate airway and ventilation are the most important factors. Supplemental oxygenation, then early intubation is critical to limit secondary injury from hypoxia. With the assessment, they have to get information about the scene of the accident by the pre-hospital team, by the paramedics. What are the mechanism of trauma? Is it fall, or he was pedestrian, or was the driver of the car front seated, back seated? What was the direction of impact? Is the face to face, or from the back, or from the side to side? What are the associated injuries, either the soft tissues or hollow organ injury or musculoskeletal or whatsoever? What are the difference in the examination? If the patient is awake, you have to ask and answer, and he will ask answer the question. If there is pain and tenderness, can be assessed. Motor and sensory exam can be assessed. Not awake, you cannot ask. Can't assess the tenderness, and no motor and sensory exam will be reliable. There are what is called a neurological shock or neurogenic shock. There is temporary loss of autonomic function of the cord at the level of the injury. The presentation of it is flaccid paralysis, loss of autonomic function, hypotension, and vasodilatation. The patient is hypotensive, vasodilated, loss of bladder and bowel control with enuresis or encopresis, with loss of thermoregulation. There is warm, pink, dry below the injury site. Warm and pink. In contrary with the hypovolemic shock, which will be cold and clammy. And there is bradycardia, not tachycardia as the hemorrhagic or hypovolemic shock. This is a table for major differences between the neurogenic and hypovolemic shocks. The heart rate here in the neurogenic is bradycardic, and there is tachycardic. The extremities here are warm. This is in contrary with the hypovolemic shock, which is cold. The urine output here is normal. As we mentioned in the shock lecture, the urine output is very sensitive indicator for the tissue perfusion, which is low, of course, in the hemorrhagic or hypovolemic shock. What are the some definitions? What is the meaning of the neurologic level? Most caudal segment, this is the most caudal segment with normal sensory and the motor function in both sides. What is the bony level? Radiographic level of greatest vertebral damage. What is complete injury? Absence of sensory and the motor function below the injury level. What is incomplete injury? From its name, it's partial preservation of sensory or motor function below the neurologic level. Neurologic assessment, there are some schools for the assessment. This is beyond our scope now. but with the complete no function below the level of injury, absence of sensation and voluntary movement in S4-5 distribution, incomplete preservation of sensation at S4, S5 distribution, and voluntary control of anal sphincter. This is incomplete. Incomplete cord injuries, there are some syndromes like the anterior cord syndrome, Brown-Sequard cord syndrome, central cord syndrome, and posterior cord syndrome. We have to remember the anatomy of the spinal cord. This is the anterior column and posterior column, our dorsal root or anterior root. There are ascending tracts and descending tracts. The anterior cord syndrome, there is loss of motor, pain, and temperature sensation. Preserved proprioception and deep touch. This is the anterior cord syndrome, which is the marked here in the red. Then Brown-Sequard syndrome. This is loss of ipsilateral motor and proprioception, with contralateral loss of pain and temperature. This is the Brown-Sequard syndrome, which is very important to detect it. Then central cord syndrome, which is marked here with the red again. The weakness of the upper limb is more than the lower limb. Variable sensory loss with sacral sparing. So in the central cord syndrome, the upper limbs are stronger, weaker than the lower limbs. The lower limbs are stronger than the upper extremities. Radiographic imaging, absence of tenderness in posterior midline, absence of neurological deficit, normal level of alertness with Glasgow score is 15, no evidence of intoxication, no distraction or injury or pain. Radiographic imaging regarding the patients who fulfill all the 5 criteria we considered low risk for C-spine injury, no need to do C-spine X-ray. For patients with radiographic imaging was indicated the AP, lateral, and open mouth views. Clearance of cervical spine injury in conscious and symptomatic patients. There is a radiographic evaluation of cervical spine for all patients who do not meet the criteria for clinical clearance as described above. The imaging studies should be technically adequate and interpreted by the experienced clinician or neurosurgeon. Plain films, AP, lateral, and open mouth view, CT better for occult fractures. MRI is very good for spinal cord, soft tissue, and ligamentous injuries, but it takes time. Flexion extension plain films to determine the stability. Radiographic evaluation, there is a mnemonic called AA, BB, and CDS. AA, we have to check the adequacy, alignment, bone deformity, base of the skull. C, cartilage. D, disc space. Lastly, the soft tissue. So again, AA, BB, C, D, S. Adequacy, alignment, bone deformity, base of the skull, cartilage, disc space, soft tissue. This is the guidelines for how to read the cervical spine X-ray. This is the adequacy, alignment, and bone, disc, soft tissue, lastly. And this is open mouth view. This is the lateral mass of C1 and lateral mass of C1. This is the C2, and this is the dens of the C2. Okay. The CT scan, as you see, this is fracture and comminution of the vertebra. MRI ideal for all patients with abnormal neurological examination should be evaluated with the MRI scan. As you see here, the spinal cord is compressed and injured. Management of spinal cord injury, the primary goal is prevent secondary injury. Okay. Immobilization of the spine begins in the initial assessment. Treat the spine as long bone, secure the point, the joint above and joint below, caution with partial spine splinting. Then spine motion restriction with the immobilization device, as we mentioned. ABC, increase FiO2, assess the ventilation as needed with C-spine control. Then indications for intubation, very important. When to intubate a patient with spinal cord injury. If there is acute respiratory failure, Glasgow score is less than 9, increase the respiratory rate with associated hypoxia. The partial pressure of carbon dioxide is more than 50, and if the and IV access and the fluids titrated to to maintain the blood pressure with 90 to 100 millimeter of mercury, and if the vital capacity is less than 10 ml per kg. Look for the other injuries, life over the limb strategy or philosophy, transfer to appropriate spinal cord injury center once stabilized, consider the high dose of methyl prednisolone. What are the principles of the treatment? Spinal alignment, spinal cord stability, neurological status. We have to do operation if there is a neurological deficit in the form of decompression by a neurosurgeon or orthopedic surgeon experienced in the spinal cord injuries. What are the types of cervical fractures? Where there is whiplash injury. And then what is the meaning of Secura syndrome, which is spinal cord injury without radiological abnormality. And you have to examine the patient clinically, despite that there is no radiological abnormality, which is common in pediatrics. As we know, the pediatric age group have soft bone, especially in the children less than 8 years of age, with inherent elasticity in pediatric cervical spine. And also there is a ligamentous injury, which is not apparent in the X-ray. And this diagnosis can be done by exclusion and confirmed by MRI, which is revealing hemorrhage or edema of the cord, and the spine then immobilized for 1 or 3 weeks to prevent further injuries. Then Jefferson fracture, which is the burst fracture of C1 ring, which is unstable fracture and needs CT scan. Burst fracture, this is fracture of C3 to C7 from the axial loading, which is unstable. Then clay Chevalier fracture, which is flexion fracture of the spinous process, the most common at C7, which is stable fracture. The previous ones are unstable all. Then flexion teardrop fracture, which is flexion injury causing by fracture of the anterior portion of the vertebral body, as mentioned here, which is unstable because usually associated with posterior ligamentous injury. Bilateral facet dislocation, which is extremely unstable. This is a mechanism of injury is flexion injury, which hangman fracture, which is extension injury. Bilateral fracture of C2 pedicles, which is unstable. There is odontoid fracture, which is happened with complex mechanism of injury and generally is unstable. Odontoid fracture type 2 is mentioned here, as you see the fracture line here. Okay. Here also the type 3, which is fractured and dislocated. Thoracolumbar fractures categorized major spinal injury into 4 groups: compression, burst, flexion, and fracture dislocation. Compression fracture, which is failure of the anterior column. It is stable, treated by thoracolumbar sacral orthosis and hyperextension bracing. If unstable, there is posterior and instrumental fusion and a progressive deformity. Burst fracture is associated with failure of anterior and middle column with axial compression, plus or minus failure of posterior column. There is compression or tensile force, most common at thoracolumbar junction. Decompression. When to do the decompression? If there is complete early immobilization, neurological outcome not changed by decompression, incomplete stabilization and decompression beneficial, there is no controversy in this, but how to do this is controversial. Posterior for decompression or anterior. There is another mechanism of injury or another injury type, which is flexion destruction injury. There is injury either to the bone or soft tissue or the both. In the form of fracture dislocation, there is associated high energy force, must have a neurological deficit, and the goal of treatment is stabilization for early immobilization. Incomplete deficit is very controversial. There is a treatment overview. We will summarize. If there is a compression fracture, the compression, if less than 40% anterior compression or less than 20% angulation, thoracolumbar-sacral orthosis. If more than 40% anterior compression or more than angulation, posterior instrumentation and fusion, surgical intervention. Burst fracture, we have to intervene with surgery or conservative treatment if the patient is stable or unstable, complete or incomplete. Flexion destruction injury, if through the bone, you have to do the TLSO, thoracolumbar-sacral orthosis, through the ligament or disc space, posterior compression, compressive instrumentation. If there is another mode of fracture dislocation, you have to do posterior reduction, instrumentation and diffusion with multiple hook system. Minor injuries, it's treated by symptomatic treatment in the form of painkillers or bracing or orthosis. Thank you.
يعطيك العافية دكتور أحمد.
الله يخليك، شكرا.
So we can open the floor for any questions. And there was Dr. Bukhari, I think he is raising his hand. So can you please unmute your mic and you can ask your question. Dr. Bukhari.
Is he hearing us?
I don't know, but he's raising his hand, but unmute.
Could be by mistake.
Maybe. طيب lower his hand. طيب دكتور حسن تفضل.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام
ورحمة الله.
أنا I mean I don't have a question for now, just to say thank you for such a nice presentation for the panelists. Allah subhanahu wa ta'ala says in the Noble Quran, someone who saves the life of one life is as if he have saved the world. So this is a great job. And by you, the information that you have transferred, we are able to do a lot in the future. Just to say, jazakumullah khairan, khair al-jaza.
العفو دكتور حسن.
السلام عليكم ورحمة الله.
Thank you very much.
طيب كان في اللي هو من ضمن الأسئلة إنه على أساس متى سيكون اللقاء القادم، سيتم الإعلان عنه في حينه إن شاء الله بإذن الله. أهم شيء إنكم كلكم تتابعوا اللي هو to follow us on Twitter, on Facebook and on our YouTube channel. We will inform you when will be our next meeting inshallah, and hopefully that all to be safe during this pandemic. And I give the mic to Dr. Muhammad Mirza.
Okay, thank you everybody for nice presentations and lectures. Thank you for all attendees. We were honored to be with you. And as Dr. Isam said, follow us, and inshallah soon we will announce activities, scientific activities, inshallah. If you have any suggestions, any questions, any topics you want us to talk about, just let us know, and we'll be very happy to talk about it and share knowledge about that. We have all specialties, alhamdulillah, surgical, medical, and we will try to help everybody, especially our friends in rural areas. Thank you very much, and see you in next meetings, inshallah.
I just posted in the chat the YouTube channel and the broadcasting that we are just doing. You can enter it at any time. It will be recorded and it will be available there 24/7 on our IMSA Tube channel. So feel free to go back there and you can review it. You can see the slides with the presentation with the speakers.
Thank you.
Thank you everyone, and Assalamu alaikum wa rahmatullahi wa barakatuh.